Good afternoon, everyone. Welcome to Health Coverage Insurance and Financial Services Committee. This afternoon, we have a public hearing and then we have a work session, and then we're going to do some language review. Before we get started, I will ask committee members to introduce themselves, starting with Representative Mastracchio.
Good afternoon. I'm Anne Marie Mastracchio. I represent House District 142, which is part of the city of Sanford and the village of Springfield.
Good afternoon. I'm Representative Josh Morris. I represent House District 91, Turner, Leeds, and
Good afternoon. I'm Rolf Olson, District 86, which is Raymond, Casco, Fry Island, and a bit of Poland.
Good afternoon. My name is Bob Foley. I represent House District 145, which is most of the town of Wells.
Good afternoon, everybody, and thank you for being here with us. I'm Representative Poppy Arford. I represent State House District 101, the western part of Brunswick.
Good afternoon, Representative Michelle Boyer. I represent House District 123, which is most of Cape Elizabeth.
Good afternoon. My name is Christy Matheson. I represent District 151, Kittery, and I serve as the House Co-Chair.
And I am Senator Donna Bailey. I represent District 31, which is Buxton, Old Orchard Beach, and Saco, and I serve as the Senate co-chair. We will open the public hearing on LD 2242, which is a major substantive rule for naturopathic doctors. And first, our analyst, Colleen McCarthy-Reed, is just going to orientate us a little bit about what's in our package before we get
Yes.
started.
So committee members know that the resolve itself is just a sentence or two that authorizes the committee or the legislature, if the committee moves the legislation forward, to authorize final adoption of the major substantive rule of the Board of Complementary Healthcare Providers. So, but what is not in the resolve is the language of the rule itself. So in your very front of your folders, you'll see a packet, a clipped packet, which will give you a copy of the provisionally adopted rule, which is shown through with track changes. So you can see it's a color, you can see the changes that were made to the existing rule through strike through and underline language, similar to how you see it in a bill. You'll also get a copy in that packet of the current rule without showing any of the tracked changes. You'll see the sort of fact sheet related to the rulemaking. And then there's also copies of the board's basis statement and the response to comments that were submitted during the rulemaking process. So all of that is clipped together for you. The pink sheet is a copy of the current law that governs the Board of Complementary Healthcare Providers. It's an excerpt from the chapter 113B. So you'll see the definitions at the front because they do relate to the subchapter that governs naturopathic doctors. So you have the first 5 pages and they include the definitions and then the board, the authority of the board and the powers and duties of the board. And then starting on page 7 of the pink, you'll see the subchapter of chapter 113B that is the statutory requirements that currently govern naturopathic doctors. So that should be helpful for you as you go through and hear from folks today during the public hearing. So,
Okay,
thank you.
just before you go, Colleen, does anyone have any questions for Colleen? Yeah, Representative Clucci.
Thank you, Madam Chair. Colleen, if we were to, so the bill that can be reported out is just adoption of the rules, so it can't add anything else to it?
It cannot be amended into an act
Okay.
because it already is a rule. So the committee does not currently have authority to make any statutory changes through the LD 2242.
Got it. Okay.
So if the committee wanted to make statutory changes, you would have to pursue another, find another vehicle for that.
Got it.
The rule at the resolve itself, LD 2242, is simply the directive to the board as to the legislature's direction as to whether or not the rule can be finally adopted as is, not authorized to go forward, or authorized to go forward with specified changes to the rule itself, but not to the underlying statute.
Okay, further questions for Colleen? Thank you. All right, with that, we'll open up the public hearing for those wishing to testify in favor.
Yeah, I think I turned the mic off.
It's in the front.
Which is in the,
Yeah.
sorry about that. Sorry.
It's such a habit.
That's
With
fun, yeah.
Colleen, you're done speaking, you turn
I
it off.
know.
Yeah.
Thank you.
Thank you.
All other duties as assigned. I will take that on. Good afternoon, Senator Bailey, Representative Matheson, and members of the committee. My name is Penny Valancourt, and I serve as the Director of the Office of Professional and Occupational Regulation, known as OPOR. And I'm here to testify in support of the resolve and in essence, support the committee's approval of the major substantive provisional rule adopted by the Board of Complementary Healthcare Providers, which is one of 38 separate licensing boards within OPOR. Again, I want to thank you for this opportunity. And while I do have 4 pages of written testimony, I will summarize it quickly in a sentence or two. And that is, first of all, I would like your support to move the provisional rule as drafted without changes. And then the second part of my testimony, while I understand this isn't the vehicle, the resolve may not be the vehicle, we are requesting the committee to consider statutory changes that makes this process more efficient and really addresses any future delays with updating the formulary as we go forward. And to that end, I was requesting a statutory change to remove the formulary subcommittee from statute. And then the second change would be to make the updates to the formulary routine technical rules instead of major substantive. And I'm happy to answer. That is a quick gloss over of my testimony, but happy and prepared to answer any detailed questions you may have.
Thank you. Questions from committee members? Representative Mastracchio.
Thank you, Madam Chair. So Ms. Valancourt, are you saying those statutory changes are changes that you're going to bring back for the 133rd as a department? Or, I mean, or is that
I'm
something
prepared
that,
to do that.
If
to
we
propose
can't-
that, if you can't, that would be on my legislative agenda going into next session.
okay, thanks.
Further questions? Representative Matheson. Choose first.
I'm sorry, could you just repeat those really quickly, the 2 statutory? I was writing and wasn't doing
Yes.
it very,
And
or
in-
just
and in
direct
fact,
me.
I
on-
have proposed language as part of page 4 of my testimony. And I'll bring your attention, the first section is to amend 125-224B such that it strikes the language by a subcommittee of the board consisting of the naturopathic members and the allopathic or osteopathic physician member. So that's the first statutory change. The second statutory change is right below, which is to remove the language under 32 MRS 12506 to simply remove the reference to major substantive and allow the board to adopt these by routine technical, which is, again, the board already has routine technical rulemaking authority. And I'm happy to give you the reasons behind that. Otherwise, I'll reserve comment now.
Representative Clucci.
Yeah, I'd be curious about the reasons behind it.
I
The-
just want to be careful not to go too far down this rabbit hole, only because it's not something we can do. But go ahead and answer it.
I'll be brief. I recognize that the formulary subcommittee at some point served a purpose, but it is the same members who comprise of the board. And this statutory requirement, if we can't obtain quorum, the rules can't move forward. So the same issue that was facing the board under LD 1128 by not being able to statutorily convene the subcommittee because there wasn't a pharmacy member, the same issues arise when you're not able to convene at least 3 people to move forward on the formulary subcommittee. So this would, again, just remove that 2-tiered step into a rulemaking process. All other boards can do their rulemaking without having to have a statutory subcommittee. This makes it consistent and streamlines it.
Further questions? Representative Clucci.
Thank you, Madam Chair. So in reading through, I was trying to understand the scope of practice for naturopaths. And in the statute, it says that there's a prohibition, right? Section 5. And Section 5D says, and just help me understand this, because it says a naturopathic doctor may not practice or claim to practice medicine and surgery, comma, osteopathy, dentistry, podiatry, optometry, chiropractic, physical therapy, or any other systems or methods of treatment not authorized in this chapter. So is that saying what naturopaths are doing now is not medicine, is not considered medicine? Because it says they may not practice or claim to practice medicine and surgery. So I don't know what that means.
I'm not sure that I can answer that question. My goal today was simply to say that the updated formulary met 2 statutory reviews by our assistant attorneys general, that this is not an effort to expand the scope of naturopathic doctors, rather to update the formulary so that they can treat patients in the way that is necessary within the statutory confines of their scope. So the rule is not expanding the scope of practice of naturopaths. It's updating the use of medicaments and medications to treat patients that align with their scope. So to be clear, this effort does not expand their scope. I would rely on the naturopath doctors who are planning to testify, perhaps to clarify your question with regard to what their practice involves exactly.
Okay, can you just help? Because my understanding was that a lot of the naturopathic practice was really preventative. And this feels like a lot of the medications are really for treating potentially like very complex diseases. So I'm just trying to understand what the scope really is and how giving access to all of these additional medications, how does that not change what they're doing? I guess I just don't understand.
Now, I appreciate that. I'm not a practitioner and I'm going to reserve, hopefully folks behind me can answer that question, but you do have representatives from the association who I think can clarify that for you.
Further questions? Representative Arbor.
Yes, thank you, Madam Chair. Yeah. As you know, we've had a number of scope of practice bills come before us, and I am absolutely not an expert on this. So what would be within this particular profession of naturopathic medicine? What would be is there any pharmaceutical requests that they could make at this committee that would be considered scope of practice, or is just everything related to their relationship with pharmacology? Is that just never considered scope of practice?
They do have the ability to prescribe non-controlled substances. That is part of their education and training. And in fact, a licensing requirement is that they do 7 hours of pharmacology continuing education. So it's already contemplated within their existing scope. But how that translates out into real practice, I think the professionals can probably answer that. And again, to be clear, my support is to move this provisional rule within the statutory confines of existing statute scope, not expanding the scope. So this is aligning what's happening today and some of the barriers that patients are experiencing because the formulary had not been updated in almost 30 years. So this is woefully, in my opinion, overdue. And it is in no way a representation for me to say that this is an expansion of scope. I want to be clear about that.
Thank you.
You're welcome.
Further questions? Representative Mastracchio.
Thank you, Madam Chair. I mean, maybe you can just, 2 sentences on why we're here with this today, because we came to this as a first step to some of the things that we were doing because of the formulary not being updated in so long. So just explain, because maybe there are people who weren't here and didn't watch us last time, just a couple of sentences why you are here and what happened.
I am here because I've been asked to be here and I showed up. I also want to point out that this major substantive rulemaking process usually takes 12 months to 18 months. We did it in almost 5. Because I heard the committee last session, I took it seriously, but I also, what compelled me, once I stepped into the role of OPOR director, that this was a rule that couldn't get lifted for a number of reasons. And primarily the reason, as of last year, was that there was a piece of statute that required a pharmacist member to serve on that formulary subcommittee, and there is no pharmacist member on the board. So when the pharmacist member on the board was removed from statute, that left the board in a space where they could not move forward without a legislative change. The vehicle for that was LD 1128. It just so happened that proposal also promoted to expand the scope. And this committee said, Penny, go do the major substantive rule, report back. Part of the major substantive rule package also highlights requests to do expansion. And our response to that proposed rulemaking was, that's a statutory change, not a rulemaking change. So I believe the second step at some point, whether it's the folks behind me or someone else, is to pick back up that scope of practice discussion. But today, in my opinion, that's not today.
Further questions? Representative Clinton.
So one of the things that I had asked, and you provided a response yesterday about the role of pharmacists in this process. And my understanding from your response is that the pharmacist that was involved in the process didn't say anything. And then all the other pharmacists that are on the Board of Pharmacy refused to provide or didn't provide any comment. And so it just to be clear, like the barrier was we couldn't get a pharmacist involved. So the resolve was, okay, move it forward. Like, let's have the boards like engage with the Board of Pharmacy. My understanding was that they were supposed to engage with the Board of Pharmacy. And it feels like maybe there was an attempt, but nobody engaged. And so
Yeah, I
I'm
don't want to
wondering why that is.
Yeah, well, that's a great question. And I would not say it's for lack of engagement or effort by the Board of Pharmacy. I'm currently serving as the director of both the office. I also happen to be overseeing the Comp Health Board and also overseeing the Pharmacy Board. So I'm the one saying, hey, here's a proposal. What do you think? And there were no issues raised. So I didn't take that as a negative or that they didn't want to be bothered, but rather they had no concerns. If they had concerns, they would have provided comment either as a full board individually or separately in their own personal capacity. But they were engaged. They just had no comment. There were no issues that they brought forward either at the subcommittee or through the rulemaking process or to me individually. But I did reach out to them.
Further questions? Seeing none, thank you very much. Anyone else in the room wishing to testify in favor? Please come forward.
Okay, I always forget to sign this.
And we will be running a 3-minute clock, so please limit your comments to 3 minutes or under. Thank you.
All right. Hi, good afternoon, Madam Co-Chairs Matheson, Bailey, and honorable members of the Joint Standing Committee on Health Coverage, Insurance, and Financial Services. My name is Dr. Elizabeth Yorey. I live in Brooks and my naturopathic practice is in Belfast. I'm the most recent past president of the Maine Association of Naturopathic Doctors and current co-chair of the Legislative Committee. And I've been up speaking before you more than once before. I'm here today specifically in support of LD 2242, the resolve to review major substantive rules related to formulary of naturopathic doctors, which hopefully that's what we're all here for as well. So to kind of backtrack and answer the question that was raised, how did we get here? Over the last 5 to 6 years, Maine naturopaths have been actively seeking to modernize our prescriptive formulary to better align with our training and modern standards of care. We first approached our licensing board, the Board of Complementary Healthcare Providers, to review our formulary a couple years ago. We were told by the board at that time that they were unable to do this, and they told us to seek legislative action for this to happen. In 2025, LD 1128 was introduced with numerous co-sponsors to try to address this outdated formulary. In April, this committee voted unanimously to instruct the Board of Complementary Healthcare Providers to review and modernize the formulary via rulemaking. The formulary subcommittee of the board, including an MD, met and worked on the rules, consulted with the Board of Pharmacy, and sent to the board, the multidisciplinary board, including an MD, an NP, a CNM, and an LAC, along with NDs, to review the proposed rules changes. They held a public hearing. They gathered stakeholder input. Again, they, to reiterate, they consulted with the Board of Pharmacy, and they ultimately voted to approve these rules changes. The rules changes, LD 2242, are now back in front of you folks to approve. I do strongly encourage you to vote in favor of these changes because I truly believe that it will make medical care better for my patients. Under the current rules, many of the medicines used to manage common healthcare conditions are not accessible, and I have to ask patients to return to their primary care doctor or send patients to the urgent care to access some of these common medicines. Even by antibiotics that are the front line for treating urinary tract infections, very common and simple situations. These formulary constraints often result in more trips to doctors' offices, putting strain on our healthcare system and the patient in terms of time and finances. Since I was last year testifying before you, I had a patient who needed an MRI to evaluate for a brain tumor. All of the concerning markers were present and an MRI was indicated. Under the current rules, there has been belief for the last 30 years that NDs cannot order imaging involving contrast. The imaging center and their supervisor rightly pointed out that the MRI without contrast that I ordered wasn't sufficient for what we were trying to evaluate and would not run the imaging. After several weeks and numerous back and forth conversations, I was able to convince the patient to have a consult with a colleague of mine who could order the MRI with contrast. That process took almost 4 weeks. Ordering contrast for imaging like MRI and CT has always been allowed under our rules, but the perception for the last 30 years is that it has not been allowed. These rules changes in front of you will lend necessary clarity to the issue of contrast and many, many other ambiguous and confusing rules in the current statute. For many of my patients, I am the only doctor they see, and am often the only doctor they are willing to see. After working to convince a patient that they needed to establish care with a primary care doctor so we can work concurrently, the patient returned to tell me that the wait times at 2 of the offices that they visited were 1 year and 3 years. And there were other offices that had close to a year wait time as well. This creates an incredible concern for me and my colleagues around patient safety and care. Please do understand, I'm not laying blame on the good, caring, hardworking healthcare providers in the state of Maine, my colleagues. It is well known that we have a healthcare crisis in Maine. I'm here today to ask for your support of LD 2242 to allow us trained and licensed naturopathic doctors to be able to be part of the solution. Help us to better help our patients and be part of a solution for the Maine healthcare system. Thank you.
Thank you. Questions from committee members? Representative Clucci.
Thank you. So with a patient that if they had a brain tumor, what would you have done?
Absolutely refer to the specialist neurology, hopefully get them hooked up with a primary care doctor so that they can actually get referrals to some of these offices as well. That is far outside of what is in my scope.
Okay. And then one of the things that it looks like I was trying to understand the formulary changes, and there are some exceptions, and I don't really understand what medications and therapies have actually been added, because it sort of went from like a full list of what you could prescribe to like just referencing a big massive list of formularies. So
Yes.
Could you help me understand what medications and therapies sort of have been added and how that it just helped me understand what you're going to be able to do that you haven't been able to do because of that?
You're absolutely right to notice that the language has changed, and part of it is because it was so confusing before. One of the things that the new language is going to allow me to do is to prescribe the frontline nitrofurantoin, I can't even say it, nitrofurantoin for urinary tract infections. It would allow me to work with patients who are on metformin, which is the frontline treatment for diabetes. I've been allowed to prescribe insulin for 30 years, which one would argue is a much higher force intervention than metformin. But because these rules were written 30 years ago, before many of these things were even invented, metformin is not on that formulary. It would be now. So we would be potentially having access to the antibiotics that are available for frontline treatment for many common conditions. It would allow us to have access to diabetes type medications. Currently, with the rules that are in front of you, there's no access to blood pressure lowering medications, which can absolutely lead to delays in care and safety considerations for patients that are having hypertensive crises. Most of the time, we have to send these people to the emergency room to try to get emergency access to these things. I'm trying to think. Those are the major classes. I do believe that I have a colleague who's going to be speaking about the change in the language structure from the old formulary to why we're asking for this different language. The thumbnail there is that it allows for some flexibility with the formulary. If we continue to have a formulary written with the language that's sitting in front of you from the old formulary, it's essentially obsolete the moment it gets passed and does not allow for any updates in medication or, again, standards of care for our patients.
Other questions? Representative Clucci.
Okay, thanks. So there is a list of exceptions. And I don't understand necessarily, where is it? Maybe it's in the pink sheet. There were like 5 different groups of medications that were exempted. And I looked up to try and understand, where is it? To just try and understand what those classes of medications were.
Yeah, I think I have a
it's like
colleague.
general anesthesia.
Mhm.
Where is this? Where's it says the? Oh, yes. Okay. Sorry. So controlled substances, I understand. So that means there's no like, you guys aren't doing like substance use treatment.
Correct.
Okay.
Anything that is a controlled substance is carved out of this
Okay.
proposal.
And then the psychotherapeutic, that's like, what is it, like SSRIs and
Yeah,
stuff like that?
antidepressants, anti-anxiolytics, because of, I believe, our laws, we're not allowed to by law prescribe those.
Okay. And then the anti-manic, aren't those a lot of this? Those are a lot of this.
That's all that
same brain,
neuroleptic category.
Okay.
Yeah, psychotherapeutics.
except for lithium. And so is that like,
There's a natural lithium salt that has been part of our formulary
so
for
that's the
30
only one?
years.
Okay.
Yeah.
And then general anesthesia. So anti-neoplastics.
Anti-neoplastics, chemotherapeutic agents,
Okay.
generally.
But then it says except topical ones in the following subcategories in oral and topical form. So what are anti-metabolites?
If I may, I have a colleague coming
Oh,
up
okay.
who's going
All
to
right.
cover some of those specifics.
Okay.
Yeah.
Yeah, because that's,
And we can
if somebody could help
absolutely-
me explain that. Yeah.
Yeah.
That'd be helpful. Thank you.
Okay, thank you.
Further questions? Representative Arford.
Thank you very much, Madam Chair. Thank you so much for being here with us
You're
today. It is
welcome.
appreciated. I just have a quick question about the terms of the collaborative relationship. It's something we discuss in every one of the different professions that we review. And there's a change made here. Can you just explain why Part C was deleted, which talks about the 45 days reporting? Do you know the part I'm talking
I
about?
don't, right off the top of my
It's
head, I
under,
apologize.
it's Part C. It just talks about that 45 days. Well, if you don't know this,
That I
don't
don't,
think
I'm
you'll be able
sorry.
to answer it.
Yeah.
Do you know of anybody who's going to be
I think we
testifying?
have someone coming up
Okay,
who can
great,
address
super.
that. Thank you.
Thank
We
you
tried to
so
divvy
much.
up labor here, so you didn't hear the same things over and over again.
Right. And I'll direct my questions
Okay,
elsewhere.
I'm
Thank you.
sorry.
No, thank you very
You're
much.
welcome.
Okay, further questions?
Right, thank you very much.
Arford, if you want to turn your mic on. Thank you. Anyone else wishing to testify in favor?
I've already submitted my testimony. Thank you, Edna. Good afternoon, Madam Co-Chairs Matheson, Bailey, and members of the committee. My name is Dr. Sarah Ackerley, and I'm a licensed naturopathic doctor and have been practicing for over 31 years in the town of Topsham and Brunswick. I have the unique perspective of having worked on the original bill 31 years ago to license naturopathic doctors in Maine. Yes, I'm kind of one of those dinosaurs, sorry. I don't feel like it though, so that's a good thing. I have also served on the board of complementary healthcare providers since its inception 31 years ago, though I am not testifying in that capacity today. I would like to offer some background on the initial decision to license naturopathic doctors from the legislative task force, which examined naturopathic licensure and our scope of practice 31 years ago. This task force, which I was a part of, included all the major stakeholders, including Dr. Garofalo, and medical doctor who is also still practicing, dinosaur like me. And the goal of that legislative task force was to determine whether or not to license naturopathic doctors and what the scope of practice was. So we met for over a 4-month time period, and after a evidence-based review, the task force did recommend licensing, not registering naturopathic doctors because of our training and scope of practice. When the report reached the legislature, it was recommended that we were granted authority to prescribe all Legend 5, Category 5 legend drugs, which is a much broader scope and less broad than what comes to you today. When the report reached the legislature, there was less understanding of naturopathic doctors. Back then, there were only 7 of us who were practicing. Now we have over 40 of us, so we are growing. So when the legislature reviewed that recommendation, they did decide to limit the formulary from all legend drugs and then decided to move to an inclusive formulary, which then Dr. Hart, who was the original medical doctor who served on the board of complementary healthcare providers, as well as myself and a couple of other members of the subcommittee, met over many more months to then write all of the medications that you see before you and that we've been prescribing for the last 30 years. As soon as it was published, as my colleague said, it was outdated, especially given that there's a rapid pace of both botanical medicine and prescription medicine research. And so that's the unfortunate part and part of why we really hope that we'll come up with and you'll pass this formulary of exclusion because it allows us to keep up with the changes that happen. In the interceding years, the New Hampshire Naturopathic Medical Board has developed a formulary that does also include controlled substances, as does Vermont, our neighboring states close by that we had originally based our formulary and our law on. Vermont has also made naturopathic doctors primary care providers. So they have...
You are out of time, so if you
Okay,
could wrap
all
up.
right,
3
thank
minutes
you. I
goes
will finish
fast.
up. So I have been part of the work with getting this this bill to you, and I have a number of patients, some of whom are here today to testify about the need for being able to update this formulary. And I respectfully ask that you support these rules as written with a unanimous ought to pass. And thank you for your time and continued support.
Thank you. Questions from committee members? Thank you. Representative Coots.
Thank you, Madam Chair. I was just wondering if you could answer any of the questions I had that I'd asked it just about to try and better understand the
exceptions to the exceptions?
Yeah.
Yes,
yeah.
absolutely. The anti-neoplastic exceptions are 3 categories, I believe. One is anti-metabolites, which are basically medications that interfere with RNA or DNA synthesis by mimicking natural substances in the cell when they go to replicate. So these are things like 5-fluorouracil or 5-FU, which is a common medication that we use for anogenital warts, for instance. Also used for actinic keratosis, so those age spots that people have, so very commonly used in primary care practice. The natural products include oral and topical forms and subcutaneous or IV Viscum album. Viscum album is mistletoe. And mistletoe has the amazing ability to work as a complementary agent in treating cancer. And has been something that people who receive special training, I have not received that training, but I have colleagues who have, and that is, they have been trained to administer that. And then hormonal agents are things that block or modify hormone signaling. For instance, patients who have gynecomastia, like young men who develop breasts when they're going through puberty, would be administered something like tamoxifen, which is an off-label use. Mostly we know about it for breast cancer treatment, but it's also used for adolescent boys so that it's quite effective for helping to treat that issue. And then the targeted miscellaneous antineoplastics are basically a new category of meds that are expanding incredibly rapidly and have the capability of being able to have biologic immunotherapy that's specific to the type of cancer that somebody has. So they are probably the most exciting new developments that we're seeing in that line.
Representative Clucci.
Thanks. So maybe this isn't for you, if this isn't your specialty, but it would be super helpful if anybody's out there to help me understand the role of naturopaths with like oncology and sort of and is that like, just help me understand, is that like a partnership? Is it a you know, we've identified that you have cancer and it's a specific kind, so we'll manage it. Like, help me understand.
Sure.
Because I know that I've seen that there is a naturopathy like specialty you can get in oncology, but Maine doesn't recognize that as a specialty. The only specialty license they have is for acupuncture. So
Correct. So there are, just like there are societies where people specialize in certain areas like pediatrics or gastroenterology, there is a specialty certification with a lot of extra training people go through and usually work at cancer centers, like Cancer Treatment Centers of America has a lot of naturopathic physicians that work there and learn and train, are trained in how to treat oncology patients. Most of the naturopathic doctors are practicing as either primary care providers, although we're not officially primary care providers, but we function as that for many of our patients. And we almost 100% of the time work with an oncologist or make those referrals for appropriate care and work adjunctively. There's a lot of things that are used naturopathically to treat cancer. And so that's why many people want to meet with us. And because of the impact of radiation and chemo, we know that one of the most concerning things with cancer treatment is that many patients don't have the nutrition, and that's part of why they decline in their care. So many people work with us adjunctively, and I don't know many. There are specialists like Dr. Barbara McDonald. She might be able to answer that question. My mother was just diagnosed with cancer, and so she's consulting with her because that's one of her specialists or specialty certifications. But they also see other oncologists.
Further questions?
Other questions?
Seeing none, thank you
Thank
very
you so much.
Others wishing to testify in favor?
Good afternoon, co-chairs Matheson and Bailey and members of the committee. Thank you for being here today. I know you all are tired and wanting to leave for the end of the session, so I appreciate you being here and working on this with us. My name is Corey Marinero, and I'm a licensed naturopathic doctor practicing in Hollowell, Maine. I've been in Maine practicing since 2012. I'm testifying in strong support of the resolve before you. regarding Chapter 6 of the Naturopathic Prescriptive Authority Rules, specifically to explain why a formulary of inclusion is the right structure for Maine's ND formulary. Rep. Clutchy, I might be able to answer some questions for you. I do have a story to share, but I'm going to share my story last if I have time. There's other points I want to make before I get there. Maine's current inclusion-based formulary has not been updated in 30 years. It became outdated the moment it was passed in 1996 and has not been updated since that time, as Penny Valancourt testified to. Senator David Rochefort of New Hampshire, a practicing pharmacist who helped create the New Hampshire formulary, strongly advises against the inclusionary approach due to regulation, the approach to regulation, saying inclusion formularies lack clarity and are almost immediately out of date. Maine pharmacists are living this problem daily. Cassie Brooks, Andrew Gray, PharmD, and Justin Levesque, PharmD, owners of Coastal Pharmacy and Wellness in Portland, wrote that the current formulary places pharmacists in the position of informally policing prescriptions without a clear regulatory framework to reference. And that given the pace and demands of a community pharmacy practice, this is not realistic or appropriate role for pharmacists. A 2025 MAND survey confirms it. 82.6% of Maine NDs report a pharmacist found the current formulary too unclear to fill a prescription with confidence. That is a formulary design failure, and it directly delays patient care. A formulary of exclusion inverts this. It clearly defines what NDs cannot prescribe, the categories prohibited by statute, including controlled substances, psychotherapeutic agents, and most anti-neoplastics, and authorizes all other legend drugs. The rule is unambiguous, durable, and self-updating as new drugs enter the market. Every state that has created a naturopathic formulary in the past decade has used this structure. To anchor these exclusions clearly, the board tied the formulary to the American Hospital Formulary Service, AHFS classification system, the universal drug classification language used by Medicare, Medicaid, and hospital systems nationwide, because Maine's own pharmacists recommended it. Natalie Gustafson, PharmD, who chairs the Prescribing Advisory Committee for the Oregon Board of Naturopathic Medicine and has filled hundreds of thousands of ND prescriptions over 17 years, wrote that she has not observed any meaningful difference in safety or clinical appropriateness between prescriptions written by naturopathic doctors and those written by other licensed prescribers. She confirmed that AHFS is working well in Oregon and specifically endorsed Maine's approach. I am out of time, but I'm happy to answer any questions based on that.
Thank you.
Yeah.
Questions from committee members? Representative Foley.
What was the story you wanted to share with us?
Oh, thank you for letting me tell that. I appreciate it. Thank you. So the story is about one of my first days in practice in Waterville, Maine. Before there were several naturopathic doctors there, it was me and one other naturopathic doctor who was also a family nurse practitioner and who sent prescriptions under that title or that license. And so the pharmacists were not familiar with the scope of practice of naturopathic doctors. And I had a family who was abjectly, destitutely poor, as one of my first families that I worked with. And they brought their son into me with a clearly recognizable strep throat and an otitis media. Confirmed the strep throat with a rapid strep test and asked about antibiotic allergies. And the correct prescription would have been Augmentin. Augmentin is a combination of amoxicillin, which to treat the strep throat, and then clavulanic acid that helps to decrease resistance to treating strep. And that would have covered the ear as well. Because of the restrictions in the current formulary, we are only allowed to prescribe antibiotics that are derived from natural things. And so while amoxicillin is derived from penicillin, which is natural, clavulanic acid is synthetic, so therefore outside of our scope. Completely arbitrary, but that's how it is. And so I could not prescribe the right antibiotic. I offered the family amoxicillin, which was a good compromise, just not the ideal drug. And they chose to, or I said, you can also go to urgent care. They chose to wait for me to be able to prescribe them the antibiotic. Then I called I called their preferred pharmacy. The pharmacist had not heard of naturopathic doctors before, pulled up our statute and told me that I couldn't prescribe any drugs, only herbal things, only herbal prescriptions. And so it took me, I'm going to say 4 or 5 hours of talking to pharmacists to be able to make the amoxicillin prescription happen. By the time it actually came through, the patient's eardrum had ruptured. And so that is a very clear example of how the arbitrary restrictions in the formulary prevented me from, and also the lack of knowledge of that pharmacist, because the statute is so unclear and the rulemaking is so unclear up until now, resulted in a direct harm to a patient and delayed patient care.
Thank you.
Yeah.
Further questions? No, thank you very much.
Are we sure? All right, thank you.
You're welcome. Anyone else wishing to testify in favor? Thank you.
Hello again. Thank you so much for hearing us today, co-chairs Bailey and Matheson and members of the HCIFS committee. I am testifying in favor of Bill LD 2242, and my name is Dr. Barbara McDonald Rogers, and I'm a licensed naturopathic doctor and acupuncturist, Chinese herbalist practicing in Rockport. I have been in the Mid-Coast since 2010, and before that was practicing in Oregon for 13 years. In Oregon, we have a broader scope. So I had a DEA number. Most of the time, I guess somewhere around 90% of the time, I never used it. But it was an important part of our naturopathic tools when our patients were suffering and the naturopathic tools either didn't have enough time or were ineffective in that case. In Maine, there are people who are really, really concerned about seeing Western doctors and or wanting to have a doctor they have a more intimate relationship with professionally, of course, and they wanted us to have more time with them. So we take up to 90 minutes, an hour with our patients all the time. I am practicing 50% oncology, and most of my referrals come from New England Cancer Specialists and Penn Bay Medical Center Oncology, Dr. Inhorn and Voisin. And I am happy to talk about any questions you have about the oncology field. At the end, I'm the daughter of a naturopathic doctor, Dick McDonald, who was president of the Maine Osteopathic Association in '83, and he testified in front of Congress, the United States Congress, to get Medicare privileges. And he told me to always stand up for my profession. In fact, he told me, don't become a DO, become an ND, because his primary in Florida was an ND. So I listened to him, and I've always tried to practice and do the best for every patient who's sitting in front of me. When I got here, I guess was kind of naive about the license and this change in how I would have to practice. And hundreds of times since 2010, I've had to tell a patient, I'm sorry, I can't prescribe that. Most recently, a gentleman who was clearly having asthma, who is very fearful of Western medicine. He'd been cleaning records and mold on them, and he wanted me to give him an inhaler. And I said, I wish I could give you an inhaler. I'm sorry, you're going to have to go to urgent care, find a PCP. And he tried, couldn't find it. You've heard the story before. This particular license, the way that, or the law, the way that it is now is really not serving our patients. So I'm happy to answer any questions that you might have. And I would really gratefully appreciate your passing this as it is written. Thank you.
Questions from committee members? Representative Tucci.
Thank you, Madam Chair. So you testified that, your dad seems to think, ND is a better profession than DO. And then there's a letter in the back also saying my, ND has superior expertise to the DO. So I'm curious what, why aren't you pushing for the full
scope of practice? I guess you'd have to ask the committee. I don't really know why we would or would not do that. All I care about is that I want to serve my patients. I've never really felt that limited with scope of practice, except for with this formulary personally. As a complementary healthcare provider, I have really great relationships with medical doctors, osteopaths, nurse practitioners on a first name basis that I send and refer patients to all the time. My patients who see Doctors Nakos and Batelli at New England Cancer Specialist, they know I'm going to send my notes and ask them, hey, do you think maybe, what about this or that? And we have a collegial relationship with them. We don't want to overstep our boundaries. We love what we do. We don't want to be assimilated into the medical profession or become osteopathic physicians. And with all due respect for my osteopathic colleagues here, I didn't mean to make it sound like we're better than you, because I know we're not. We just play different roles in healthcare. My dad was a manipulative therapy guy, and I prefer just more of a primary type of situation. So there's a lot of room for all of us, and so many towns don't have enough people. And I know personally many young naturopathic doctors who wanted to come here, but they were like, oh, but I can't give an antihypertensive. I'm going to be the only doctor. You want me to live in Dover Foxcroft, and I'm the only naturopath up there, and I can't give that. I'm going to have to get help. So I don't know if that answered your question or not.
Yeah, I mean,
I can, yeah, follow up. Go
well,
ahead.
I'm just curious if there's any, sort of types of medicine and disease that you don't think that you should be practicing, that an ND should be practicing.
I think we're trained very, very clearly at where our lane is. I'm not an oncologist. I don't want to be an oncologist. I would never presume to do that. So that's one. I wouldn't want to be a neurologist. I'm not when my mother got Alzheimer's and my father got Parkinson's, I went and sat with them at Dr. Lash's office, who I'm friends with, and I said, can you help us? I've tried, giving them choline and fish oils and all of those things. I do craniosacral and acupuncture. Can you help us with medications to delay it? I'm not asking for those drugs. I don't want to prescribe those drugs. Is that answering your question?
So are those like dementia and Parkinson's, those related drugs, are those included in the formulary
Not to my
expansion?
knowledage.
Okay.
Somebody else could answer
Yeah,
that.
no, it's just because I was trying to go through and trying to understand what was.
I would want to
what
understand
was
too. I
excluded,
totally
'cause
don't.
it just-
I'm glad I'm not in your position, Representative. I respect that you're trying to figure this out. Thank you. Any other questions? Thank you for your time. Oh, I'm sorry. Representative Arford.
Yeah, I'm just because you've been I know there's someone else that's going to be coming up, but my question is, I want to understand the umbrella under which drugs or pharmaceuticals are prescribed,
Sure.
and are the overseeing of of the drugs that you prescribe during your first year of practice, is that the only thing that you are supervised in? I'm just curious about that.
Yes, correct. We have a portion of time when we first get here. It was a long time ago, so I'm a little fuzzy on the details. But where someone would check and make sure we weren't messing up with
Mhm.
our prescriptions. The pharmacists themselves also will say, oh, correct the way the prescription's written or something, and say, can you clarify? But I think our license is written such that it trusts us to have been trained properly to prescribe those.
Okay, great. Thank you.
Sure.
Further questions? Representative Clucci.
Thank you, Madam Chair. So in terms of getting that training, so you
Uh-huh.
feel comfortable, it looks like the required clinical care is like 1,200 hours. Can you talk to me more about what does that 1,200 hours look like? Is it in like a naturopath practice, or is it in a multiple practice settings where you're exposed to like different levels of sick people and different types of diseases, so you really see the full scope?
Sure. Well, back when I went to school, which is 30 years ago, and I'm pretty sure it's the same now, we have 2 years of taking all the ologies. So we take psychology and physiology and biology, and we have a cadaver that we have to learn anatomy and physiology with. We learn all the pharmacology classes. My understanding is it's similar number of hours as our colleagues. colleagues. And then we have to learn the same diseases. So say cardiology, for example, we learn the naturopathic tools and the Western medicine tools, and when we would need to employ them. And then we take board exams saying, okay, so in what scenarios would you need to refer this patient to a cardiologist? And then we have 2 years of clinical rotations. We start with what's called hydrotherapy. And then we have a clinic where you have a primary, a secondary, and an intern or a resident, and then the doctor who's supervising at that time. That's in a naturopathic clinic. In Oregon, we ran all of the community clinics for homeless people. And so we had to do a rotation. I was in gynecology at that time. And so we would do practicing gynecology, and the physicians from Oregon Health Science University, those were MDs, DOs, residents from there, would work alongside hand in hand with the naturopathic doctors. We would have free things that we could use from botanical medicine or medications that were samples and things like that for, say, a yeast infection or whatnot. And we would be very clear about, okay, well, this needs a surgical technique. In Oregon, we could do minor surgery, but in that particular setting, we would allow the OHSU residents to do a lancing of a boil or something like that. And when I did my residency, it was a 1-year residency, was in that clinic. So then I was supervising patients, but we don't have hospital training, and really respect our colleagues in the osteopathic field and the medical field for when that's needed, for sure. Yeah.
Further questions? Seeing none, thank you very much.
Okay, thank you. Appreciate your time.
Others wishing to testify in favor?
Right. Good morning, Chairs, Representative Matheson and Senator Bailey and members of the committee. My name is Dr. Katie Morrison. I'm a naturopathic doctor practicing in Rockland and the Vice President of the Maine Association of Naturopathic Doctors. I am testifying in favor of LD 2242. I'll try to be brief. There are over 34,000 Mainers currently under the care of a naturopathic doctor in Maine. I want to share what we're seeing on the ground for those patients. In 2025, MAND surveyed our members about how the current formulary affects patient care. 22% of patients have experienced a delay in care because their ND could not prescribe a needed medication, with some practices reporting delays for up to 75% of their patients at any given time. A third of patients have had to see another provider just to get medications adjusted, adding redundant visits and costs to an already overtaxed system. And over 91% of NDs report diagnosing acute conditions that they are trained to treat but cannot because the formulary won't allow it. Those situations generally result in unnecessary referrals and sometimes in care that comes too late. I've lived this. I recently had a patient come to me with an acute viral condition requiring a time-sensitive antiviral. I made the diagnosis, I knew the treatment, but I couldn't prescribe it. By the time the patient got in with another provider, the treatment window had closed and the condition worsened. This didn't need to happen. And this isn't an isolated incident. I've had patients with high blood pressure readings, high enough to prompt treatment, who have had to wait longer than is clinically safe for medication changes because I cannot prescribe antihypertensives. These patients don't meet the threshold for emergent care, but they need timely intervention. In at least one case, I had to send a patient to the emergency room for a simple blood pressure medication adjustment because they did not have an active relationship with a PCP in the area. I also recently had an uninsured patient with severe allergies that were significantly affecting her daily life who needed a medication called a leukotriene inhibitor. I had to refer her to an ENT specialist, costing her hundreds of extra dollars out of pocket and prolonging her suffering for a medication I was fully trained to prescribe. These proposed rules would fix that. They've been approved by a subcommittee that includes an MD and an NP, and just an MD, vetted by the Pharmaceutical Board, and reflect 30 years of safe prescribing by Maine NDs with 0 disciplinary infractions related to an error in prescribing. Lastly, it's worth noting that NDs in Maine actually have stronger consumer protection provision around malpractice insurance than MDs. While no medical provider in Maine is statutorily required to carry malpractice insurance, NDs are the only providers required by law to disclose to patients if they practice without it. And in practice, the vast majority of NDs do carry coverage. I urge you to support the rules as written. Thank you.
Thank you. Questions from committee members? Representative Harper?
Yeah. Again, just in an attempt to get the umbrella, do naturopaths generally practice independently or do you practice in groups generally? Or is this just a wide variety?
It does vary. Most of us have our own practices. There are some people who have smaller group practices, but in general, we're independent.
And does it make, once you're licensed and complete your education and go out to start practicing, are these requirements at all in any way different if you're part of a group practice or if you're practicing independently?
No, it's not the same.
And then the final question is, do you ever practice in conjunction with other professions like
All the time.
MDs? I mean, in the same building, like
Yeah.
you share a practice?
I have a nurse practitioner who works in my office and we talk about cases all the time. I know that's the case for a few other providers in the state as well.
Thank you very much.
Yeah.
Further questions? Seeing none, thank you very much. Others wishing to testify in favor?
Hi, Co-Chairs Bailey, Matheson, and members of the committee. I'm Dr. Nicole Egenberger, and I've been a naturopathic doctor for 22 years, and I'm here in support of these new rules. I'd like to address some of the concerns raised by our colleagues. The packet you have in front of you by the MAND addresses these all in detail, so I'd encourage you to look at that. It includes letters from MDs and pharmacists who know our prescribing practices very well, so that they might be able to answer some questions. Perhaps most concerning, I would say, is the misrepresentation of naturopathic medical education. There's concern that our accrediting body, the CNME, doesn't mandate pharmacology hours or a curriculum. And this is true. It's also true that the accrediting body for medical schools, the LCME, don't do that either. And I've included the standards of both. I don't just want to say this out of turn. I've included the standards of both in your packet so you can take a good look at them. You will see neither specifies required hours or curriculum for any of the subject matters. Accreditation bodies don't really do that. They set outcomes-based standards and leave decisions about the curriculum to the schools. You will see that the naturopathic accreditation body is in fact quite prescriptive in laying out what must be taught. It lists pharmacology and pharmacognosy. It lists the major clinical disciplines. So you'll see there it'll say gynecology, cardiology, pediatrics. So we have to take courses in all of those subject matters. And it specifies the numbers of clinical training hours that a student must receive. A similar concern is that pharmacology hours vary between naturopathic colleges. This is also true, and true of medical schools. To demonstrate this, you'll see a 2021 study looking at how pharmacology is taught in medical schools. There is a wide variance in hours, anywhere from 10 to 85 standalone pharmacology sessions, depending on the school. But this just reflects a move to an integrative curriculum, which seems to be the gold standard in medical education. It's where pharmacology is taught with relevant subject matter. So instead of having like a standalone pharmacology class and seeing 100 hours in that, you're going to see a lot more hours spent in cardiology, where you're going to learn about a heart problem and then also learn about the heart drugs that are going to teach it. That's where the pharmacology is occurring now, instead of in a pharmacology course. So I'm sure you want to get a sense of pharmacology still. So the American Association of Naturopathic Medical Colleges put together a really detailed outline so you can see where all those hours might occur. And they also put together a letter just attesting to the fact that an integrative curriculum is really the direction that a lot of medical education is going, including nursing. So how can we be assured that NDs are competent, though? This was another question that was raised, and rightly so to consider that. I would say the proof's in the pudding. We've prescribed safely for 30 years, and in surrounding states with much broader formularies, they have really good safety data, and that would be in Appendix 3 in your packet if you'd like to verify that. And we also have safeguards. To be licensed in Maine, we have to pass the national board exam. Then we have to be reviewed by MDs for a year. All of our prescriptions are reviewed. So of course, if anybody was really concerned about negligence or incompetence, they could report that to the board. And finally, MDs must have 7 hours of pharmacology credits every year to make sure we stay up to date. So implicit in any formulary, there's a level of trust in the profession, right? In individual practitioners to prescribe according to their expertise. And no one practitioner is going to be able to practice and prescribe every single drug. They are going to stay within their lane, use their expertise, and refer as necessary. I see my time's up. I was going to speak about IV therapy. If anybody has questions about that, I'm happy to answer.
Great, thank you. Questions from committee members, Representative Harper.
Quick question.
Yeah.
If you could turn your mic on.
Thank you. Thank you, Madam Chair, and thank you for being here with us.
Absolutely.
You mentioned reporting to the board. You're talking about the Board of Complementary Medicine.
Exactly.
How would the patient, or how would someone who had come to see you know to do that?
Well, I think they go on, you can go onto the, I think you would do, if they did a search about licensing, they would find like Maine naturopathic license, they would find the office that Penny is involved with. And there is a way to submit a claim on there. I think Penny might be able to speak to that a little bit better, but there's a way to submit a complaint. So complaints can be brought up to the board about any kind of negligence.
No, I'm not. Thank you so much for that. What I'm talking about is if I was disgruntled in some way, anything. This isn't true. This is true of all professions,
Yeah.
this question that I'm asking now, but how would the patient sitting in your office and then leaving, and going home, know that they could actually contact a board to register a complaint and then even have any idea what board to look at? And let's say this person is not very literate and online searching, like using search engines. So they don't really have that skill set on board. So how would they, I mean, I guess what I'm getting at, do you provide patients with that information that if they are concerned, they can contact the board to register a complaint or any information to patients about that?
Well, we do provide extensive informed consent. That's a real part of our training in naturopathic medical school. I don't believe that Maine mandates that we put that on the informed consent form. But I know that most of us have our license clearly visible. That's a very important part of it. So the license is clearly visible. It does have the office that issues the license and your license number. So I would say that is one vehicle that they could use. But I don't believe that is a mandated requirement on the informed consent.
And I don't mean to pick on you because
No,
I think
totally
this is
fine.
true of all the professions, that it would be difficult for a patient to know
It's a really good
how to
point.
contact a board and how to go through that process.
Yeah.
But thank you very much.
Absolutely.
Representative Clucci.
Thank you, Madam Chair. Along those lines, do you think that the patients that are coming to see you understand the difference between an ND and an MD?
I would say.
Because I'm
almost
asking,
always.
because like earlier today, I looked at a few ND websites and some of the language I saw was like, our curriculum's basically the same.
Yeah.
And in addition, naturopaths can do all of this other stuff.
Right, right.
But what's sort of omitted there is the 3 to 7 years of clinical residency.
Yeah, right.
And so
right.
I feel, and so is there ever any discussion with your patients of like, my clinical experience has been X versus, just want you to know, I can't manage all aspects of your cancer,
Yeah.
but I can act,
Yeah.
I'm just,
Absolutely. It's a really good question. I would say that that conversation occurs with every single one of my patients. So it is often extremely important that we emphasize the need for primary care, primarily because of insurance, just to be able to be connected into a lot of specialists. That is the primary gatekeeper for that mechanism. But I would say too, diagnostically, we really know how to stay in our lane, right? We are trained as primary care. So you will look, if you look at the standards of competency, which is set by the colleges as a group, it does say they train us for primary care because in many states, that's what we act as. But we know when we need to refer, right? So if a major disease comes up, we are of course referring to a specialist immediately. And that is what we would tell our patients. But in addition to that, we're always talking about the difference in approach, right? We have quite a difference in approach in terms of how we think about trying to help people get well. The similarity would be when there is an emergency situation, we know when we need a medication to be used. And I would say that's where we would likely act quite in a similar manner to our medical colleagues. But when we are approaching an illness that's being well managed, we would probably look at nutrition vitamins, herbs to see how we can better support them, which might be quite different. And that's a conversation we're having all the time. But I would say in order to deliver informed consent, we have to present the patient with all the options. So say someone has mildly elevated cholesterol, the doctor's saying, look, if you don't get this down, you might have to consider a statin. My job is to say, a statin is a very good option. Here's what it might do. It might actually lower your cancer risk. Here's all the benefits. Here's some of the side effects. Here's some of the other things we could try, but let's make sure we retest in 3 months, because if your cholesterol keeps going up, I am going to need to refer you back to your cardiologist to make some decisions about how best to treat you. So that we very clearly communicate that.
Further questions? Seeing none, thank you. Thank you. Anyone else wishing to testify in favor?
Co-chairs, Madison and Bailey, and members of the committee. My name is Alina Opalnik, and I live in Lewiston, Maine. I'm currently 8.5 months pregnant, and I am under the wonderful care of my wonderful naturopathic doctor, Sarah Ackerley, that you've heard earlier. I'm here to support the proposed rule changes that would expand the access of treatments, and the one that I'm experiencing is IV therapy. Well, that I need to experience and, get the IV therapy. I'm anemic, and the IV therapy has been an important part of my care. Right now, I have to travel all the way to Camden, Maine. It's about 1.5 hours one way to receive a treatment. At this stage of my pregnancy, it's kind of a far travel and physically difficult and exhausting. My veins are pretty fragile right now at this point of my pregnancy, and it's a whole ordeal. I have to pack food with myself. I have to bring all this stuff so I can eat and treat my body before I do the IV therapy. I have to get there earlier so I can stay calm and my veins can get the IV treatment. Also, after receiving the IV treatment, it would be very beneficial to just able to return home quickly and rest so my body can recover and absorb the treatment instead of facing a long travel again to go back home. My husband and I are planning to have more kids, God given, and I know I will need more treatments like that in the future. So having access to these treatments closer to home through my naturopathic doctor would make a significant difference for us, for me and my husband, and for others who face similar challenges with distance pregnancy and chronic conditions. I respectfully ask you to support these rule changes so patients like me can receive a timely, accessible care in their own communities. Thank you so much for your time and consideration. Do you guys have any questions?
Okay, thank you. Thank you for being here. Any questions from committee members? Representative Arford.
Yes, thank you, Madam Chair. I'm just curious. You're from Lewiston, correct?
Yes.
I'm welcome here, by the way, and thank you for coming. I know that there's 2 hospitals in Lewiston and numerous clinics, doctors. So why is it necessary for you to travel so far to get an IV treatment when you could go to an IV
That's a very good question.
clinic at one of the hospitals?
Yes, no insurance. And so because of lack of insurance, it's very expensive at the hospital, even one treatment comparing to going and getting at the naturopathic doctor.
Thank you very much.
Yes, absolutely.
Further questions? Seeing none, thank you very much. Oh, Representative Tomato.
Thank you for being here. Boy or girl?
Boy. It's a boy. First boy, yes.
Congratulations.
Well, first baby and a boy. Thank you so much.
Well, good luck to you.
Thank you.
Anyone else wishing to testify in favor?
Not my forte, guys. Give me grace. Do I need to sign this?
Yes, please.
Thank you. All right. Thank you so much, Senator Bailey, Representative Mathiasen, members of the committee. If you can't understand me, ask me to repeat. I'm working on it. Thank you for the opportunity. I've been a few steps ahead of the Grim Reaper for a little over a decade now. And I can't say I'm yet cancer-free, but I'm remained without any new lesions for 3 years, which is the longest period in a while, so knock on wood. So along with chemotherapy, radiation, I've endured 9 surgeries, the last one in Boston, 13 hours. Anyway, a lot going on here. And when you have all those therapies, with each new occurrence, there are new problems and new residual side effects to manage. It's just part of the game. I'm grateful to my PCP, my surgeons, and all the many professionals along the way who have helped me to get this far, who've made it possible for me to actually talk with you. My speech therapist would be thrilled. Believe it or not, she would. One person I'm incredibly grateful to is Dr. Corey Marinaro. I'm going to cry if I don't be careful. I was encouraged by my sister to seek out her care. My sister, by the way, is brilliant. You see, mainstream medicine is great, but it's limited. After surgery or chemo or radiation, I'd be left with unresolved symptoms, adrenal exhaustion, chronic headache. I've had one for 3 years. Pain, fatigue, brain fog, muscle cramps, constipation, it just goes on, right? And I would, of course, share these with my PCPs, my surgeons, my therapists, and everybody. And after a fashion, they would say, just be patient, it takes time, give it a rest. And they would give me pain meds for a little while and then stop it and say, take Tylenol. I felt dismissed, unseen, unheard, and my symptoms continued. Don't get me wrong, I received good care. It just didn't go far enough. If my complaints didn't fall into a nice, neat little box, they had little to offer. So I believe Dr. Marinaro is the reason I am here today doing as well as I am. She heard me. She listened to me. She dug further, ordered more tests, in-depth labs, provided therapies not offered by my PCPs, ordered medications, educated me about those medications, how they affected my body, what to expect for reactions. She prescribed things to help resolve the issue, not just the symptom, but the main problem that caused the symptom, which I think is a failing of Maine medicine. We treat the symptom, but not the root. For instance, I've got a lot of scar tissue. She prescribed Inflaquel. It's a proteolytic enzyme that helps break down scar tissue adhesions and inflammation. She prescribed liposomal glutathione, which is also produced in every cell in the body. It's called a master antioxidant. It supports detoxification, maintains cellular health, neutralizes free radicals. I know this because she told me. Sucralfate forms a protective barrier around the stomach. I get a little upset once in a while, a little depression, a little nerves, and my stomach was going wacky. Sucralfate helped. My PCP didn't offer that. According to my PCP, my thyroid's doing fine, but I didn't feel fine. So even though my symptoms were screaming thyroid issues, the labs didn't support it, so the PCP did nothing. I went to her. She dug a little deeper, ordered more tests, found out there is a problem. We can probably take care of that. She prescribed medication, therapies, life changes, and things I could do. It made a difference. She always explained what the issue was probably doing and how the medication would help. Anyway, I was going to go on and name a bunch of other medicines, but you get the idea. If I had an issue, she heard me, she looked for a resolution, she told me about it, and we tried it. Sometimes it worked, sometimes we had to do more. Dr. Andrew Weil is a well-known published doctor who promotes integrative medicine. And he commented that should he ever get in an accident, he didn't want to be brought to an herbalist, of course. He wanted to be brought to a trauma center, but as he was healing, he would surely benefit from the aid of complementary medicine. In the process of healing, all modalities should be available. to encourage health. Health is not just the absence of disease, it is a state of complete physical, mental, and social well-being. The body has an incredible ability to heal itself. It seeks homeostasis, but it sometimes needs help achieving that balance. You can't simply treat the symptoms, which sadly I feel is how mainstream medicine operates. You have to look at the whole person, and that is what functional medicine, naturopathic medicine does. And their ability to prescribe the drugs they need to prescribe for people like me, so I don't have to run back and forth. I got lucky. My PCP was very willing. I was very frank. I was working with a naturopathic, and she was very willing to work with me. And there were things she couldn't prescribe that my doctor was willing to do after reading the notes and conferring. I got lucky. Not all doctors will do that. It did cost me more if I had to go to her in addition, because as they say, insurance doesn't cover most of what she offers. So I am here in support of this bill as proposed so that she can treat me the way I need to be treated without delay. Thank you for your time. I appreciate it.
Thank you. And we're glad you're here. Questions from committee members? Thank you
Thank
very
you.
much. Thank you for sharing your personal story.
Have a good day.
Co-chairs Matheson and Bailey and members of the committee. My name is Melissa. I live in Hope and I have been seeing a naturopath for the last 19 years, and I support the new formulary rules as written. Ideally, I'd love to have a team of MDs and my ND for my care. But I'd like to share why I see my ND as my primary practitioner and hope that she would be able to treat me as the previous speaker described. I feel that there are some patients who need different answers to get better. NDs are detectives that help people when others can't. I suffered from chronic sinusitis, migraines, arthritis, and rosacea for 10 years before meeting Dr. E. I had seen the best doctors in New York City. I had multiple surgeries on my sinuses. I was going to have surgery on my arthritis, and I used all the medications they prescribed dutifully. Finally, my ENT told me I had the largest file of all of his patients. He gave me a hug and said I should move because of the allergens, because he had no idea why I was getting sick 6 to 8 times a year. When I found Dr. E, she was curious and immediately had ideas about what I should do to get to the bottom of things. We got to work on my inflammation and my sinus infections cleared up. So did everything else. It took a lot of detective work, but we figured it out. She also helped me with my Hashimoto thyroiditis, autoimmune disorder. When I went back to my doctor feeling better than I had in years, he dismissed it. He wasn't sure of NDs, he wasn't curious about how I got better, and he wasn't willing to work with her. Next instance, I had been on a prescription for my thyroid since I was 28 years old. My naturopath recognized that I needed T3 and my unexplained hives was caused by the hypothyroidism. She monitored my medication and my supplement closely, and I felt great. During my pregnancy, I was forced to see a specialist endocrinologist, and he made me switch my medication because he wasn't familiar with the medication that I was currently on. My issues came back, my hives came back. I pleaded with him to go back to the compounded formula, and after several weeks he did. My issues resolved, and I had a healthy pregnancy. Once my daughter was born, I felt great. 6 months went on and I felt amazing, but routine labs came back with a slightly low TSH, and he insisted I stop my medication. I protested, I begged. I had been on medication for 20 years at that point, and he refused. He wouldn't speak to my naturopath. He wouldn't have a phone call. He wouldn't even look at her website. Within weeks, I felt horrible. I had dozens of symptoms that came up, and when I almost fell asleep driving my car one morning, I get upset thinking about it. I begged him to do labs, and my TSH was over 100. I was very sick. Then he called me back, and then he was listening to my naturopath. it took me several years to recover from that change in medication. Several years later, I was seeing an NP that was more than happy to work with my naturopath. She left the practice, and the MD in charge of that practice called me on the phone and told me that he wouldn't be continuing my care. And when I pushed him, because I knew what not having thyroid medication could do to me, he said, quote, "I don't believe in naturopathic care." But he told me he would write me one prescription as a courtesy. And then he broke up with me and fired me as a patient. And I was left looking for another primary care physician, which is quite difficult in Midcoast, Maine. I hope these stories make clear that the idea that patients can simply see another provider for a prescription when they're working with a naturopathic doctor isn't the reality. You're forcing someone to try to cram a complicated story into a quick visit with the doctor and expecting them to understand the supplements and herbs you're on, and the reason your ND feels a medication is challenging. It's a challenging thing, and at best, it meant I lost my primary care, and it faced years trying to get back on track. I know you're trying to understand that if naturopathic doctors understand pharmacology. I think they do. My ND caught a drug reaction to doxycycline. My ND knew I had a genetic variation called CYP2D6 that makes me more predisposed to this type of reaction, and she was the one who caught it. She sent me back to my prescribing MD. He missed it and told me, "Doxy is hard on everyone." Meanwhile, my heart was racing, I couldn't eat anything, and all the skin on my hands and feet were sloughing off in sheets. Another, when Dr. E prescribed my hormone.
If you could try to wrap
Oh,
up.
sure. I have one last thing. Okay. HRT, she walked me through the benefits, incurred a mammogram. When I said no, I did it. I had a symptom. She referred me to Penn Bay Imaging. Everything turned out okay. My health improved dramatically when I turned to naturopathic care 19 years ago. And when my MD works with my ND, it's amazing, but it's very, very difficult. And so not only are MDs knowledgeable and confident, they've shown you that for 30 years. This formulary is not an overreach. It's still more limited than the other states and friends that I have in Vermont and New Hampshire. I would love to see us untie the hands of the naturopathic doctors so they can help more Mainers, because I honestly am not sure if I'd be here without the help of my naturopath, because I've left out a dozen more examples that I wanted to share. Thank you.
Thank you. Thank you for sharing your personal story. Questions from committee members? Representative Arthur.
Sure. Yeah, thank you, Madam Chair. Have you written these other examples in your testimony?
I had written them and I had different, but then I was told it was 3 minutes, so I edited it and my naturopath helped me.
So just so you know, if you provide a written copy of your testimony, we will eventually get a copy of it and be able to read your other stories.
Well, I did submit it online, but you
Okay.
also have a character limit online.
Oh.
And so my naturopath helped. I tend to be very detailed and write a lot. And she helped me figure out what you didn't need to hear to get the gist of it.
Well, thank you so much for your commitment to
Yeah.
educating us, if you
Yeah,
will.
and I strongly support you
Yeah.
pass it as written.
Thank
Thank
you.
you.
Anyone else wishing to testify in favor? Oh, Representative Flynn, go ahead. Almost.
Hi, thank you. Hi, thank you, members. My name is Stephanie Baker, and I'm a registered nurse from Falmouth, Maine, and in support of the scope of practice increasing for naturopathic doctors in Maine to include specifically talking about the prescribing and administration of nutritional intravenous therapy. As a registered nurse, I've seen firsthand the significant impact that delayed access to appropriate nutritional support can have on patient outcomes. Many patients suffer from conditions that impair their ability to adequately absorb nutrients through oral intake. These include but are not limited to gastrointestinal disorders, Crohn's disease, irritable bowel syndrome,
and other malabsorption syndromes. In these cases, oral supplementation is often insufficient, leaving patients nutritionally depleted for extended periods. The same goes for post-chemo patients and diabetics and others with infections that go awry very quickly. Currently, Maine NDs are restricted to administering for hydration only, despite their extensive education and clinical training for phlebotomy and IV therapy. Expanding their scope to include this nutritional IV therapy would allow these qualified providers to deliver timely, evidence-based care that directly addresses their patients' needs. In my experience, delays in receiving this care, often due to limited access to primary care physicians, can lead to worsening conditions, unnecessary suffering, increased healthcare utilization. Many patients wait weeks or months or even years to see a medical doctor, during which time their nutritional deficiencies deepen, their overall health declines, and this will result in avoidable emergency department visits and hospitalizations. Earlier interventions with IV nutritional therapy could significantly improve these outcomes for patients with these chronic conditions. Timely replenishment of essential nutrients may reduce disease exacerbations, support their healing, and in some cases help prevent the need for surgical interventions. Surgery, while sometimes is definitely necessary, it often will provide only a temporary relief and may further compromise nutrient absorption in the long run. Allowing NDs to provide nutritional IV therapy would improve access to care, reduce strain on the healthcare system, and offer patients a proactive approach to maintaining and restoring their health. It's a practical, patient-centered solution that aligns with the realities of our current provider shortages and the growing demand for accessible, effective care. I respectfully urge you to support this expansion and scope of practice for NDs in the state of Maine, and doing so will empower our providers to better serve their patients and contribute to a more responsive and efficient healthcare system. Thank you for your time and consideration.
Thank you.
I did it under 3. I was so
You
afraid I was
did?
going to go
No,
over.
you were perfect.
I do
Thank
have a
you.
story if there is time that permits. Yes.
Okay, Representative Matheson. You.
I just want to clarify my understanding. My understanding is that IV therapy has been part of their scope of practice for the last 30 years. Are you indicating that it hasn't been? I'm sorry, I just wasn't quite sure. of
That's
the
fine. Yeah.
testimony.
For hydration only.
So you're talking about just modernizing what can be administered, but they have
Right.
IV therapy under their scope of practice?
They do, but just for hydration only. So essential nutrients, trace elements, and oftentimes they're just not provided for in many, our patients here they have already indicated the lack of that.
Thank you. Really appreciate that clarification.
Further questions? Seeing none, thank you very much.
Thank you.
Anyone else wishing to testify in favor?
Good afternoon. My name is June Holman. I am from Westbrook. Appreciate the time to speak to you, co-chairs and the board on this issue. I'm here to support this bill because I believe that Mainers should have easy access to IV nutrients, especially in the state of Maine. I'd like to share a few recent experiences that I've had with IV vitamin C, just one of the many resources that this bill will open up to Mainers who are wanting to improve their immunity, nutrition, and overall health. I learned of the many benefits of IV vitamin C when my father was diagnosed with cancer at the age of 83. The VA had agreed to pay for successive IV vitamin C infusions as a means to support his strength, health, and immunity during extended chemotherapy treatment. My father's MD declined to prescribe them, citing that he's bound by rules that prevent it. When my father developed a very large septic boil, he started on a strong antibiotic, and we were instructed to go immediately to the ER for inpatient IV antibiotics if the red area increased, and it did that night. I was very fortunate to have the email address of an integrative DO who did administer IV vitamin C. He agreed to give my father an IV vitamin C treatment before I took him to the hospital. We agreed that this was important because we knew that once he was admitted in the hospital, the protocol would not support it. After the IV was completed, the redness around this boil was reduced to nearly 50%. There was no longer a reason to hospitalize him. He was saved from the discomfort, the time, and the cost of an unnecessary hospital visit. After a few months of chemo, my father developed severe chemo-induced lung problems, which resulted in the need for continuous supplemental oxygen and the use of a wheelchair for mobility. I arranged for 2 IV vitamin C treatments, and within 2 weeks, he was off of oxygen and walking on his own, starting just 12 hours after the second treatment. In 3 months, we had a follow-up with the same MD that could not prescribe IV vitamin C. He said, "I didn't think I would ever see him again, and I certainly didn't think he'd be off oxygen and walking. And even though I can't support what you're doing, I'm glad you're doing it, and I think you should keep doing it." He was, of course, referring to the IV vitamin C infusions. I myself recently had a sudden illness and wanted to receive IV vitamin C treatment on a weekend. The regulations did not allow that my ND could do that for me, but he agreed that it would help me. Unfortunately, the only facility available was a commercial spa-type location. On the intake, I talked for less than 5 minutes with an MD over a tablet in a Zoom call, probably not here in Maine, to determine what was safe to give me. I was literally ordering my IV nutrients from a menu, just like a restaurant. Wouldn't it have been better for me to have my own my own ND prescribe and administer those nutrients to make sure that they were right amounts and safe and appropriate? I stand firm on my wish that everyone in Maine should have access to these effective integrative medical therapies as an option, so that we can get the health care that we need from our local, accessible, and highly qualified naturopathic doctors. Thank you for your time.
All right, thank you. Questions from committee members? Seeing none, thank you very much
Thank
for
you.
being here. Anyone else wishing to testify in favor? All right, Representative Flynn, we'll try again. Yes.
Good afternoon, everybody. Thank you. I really wasn't planning on testifying today, but hearing what I'm hearing, I think it's appropriate that I do. I was one of the original co-sponsors to the bill that we presented last time. I am Paul Flynn. I represent District 63, Winslow, Albion, Freedom, and Unity Plantation. I had shared with this committee last session that I had experienced a medical condition that required quite a bit of care. I was diagnosed with microscopic colitis by a medical doctor in 2024. At the time that I was diagnosed with the disease, I was given options of, at that point, given the progress of the disease, either a steroid or surgery, if that didn't work. I opted not for the steroid, opted instead to attempt to manage this disease through diet. I incorporated the support of my naturopathic doctor, Dr. Yuri in Belfast. She had put together a celiac-type diet for myself, and I went from 130 pounds to 175 pounds. Back in November of last year, I began feeling a bit of a flare-up. I would get them periodically. I would manage it through diet. And I had another flare-up that doesn't seem to want to go away. I am now standing in front of you at 140 pounds. About 2 weeks ago, I realized it was time to proceed with the next course of treatment, which would be the steroid, which is what the medical doctor had suggested 2 years ago. In talking to my doctor, my naturopathic doctor, on Sunday night and then into Monday morning, she advised I go to the emergency room, which I did on Monday. I spent 10 hours in the emergency room on Monday, attempting to see a doctor to simply get a steroid prescribed for myself on a condition that has already been diagnosed. I was told on Monday that I would have to wait for another colonoscopy to confirm the microscopic colitis, which was already told I have. And I have to go see the GI specialist prior to receiving the medication I so need. So right now I stand in front of you. My wife was trying to make the appointment this morning. I think she's got one for me next week to get a colonoscopy. Perhaps they can rush me in, and then maybe I can get that steroid that might help me. And in the meantime, my system is continuing to be ravaged by this. There's damage being done to my body, to my system. Not to mention the fact that I sat in an emergency room for 10 hours in Augusta on Monday, and I didn't need to be there. I did not need to be in that room at that time. There were people who needed care more deeply than I did. But at that time, the only way I could get what I needed was to go through the emergency room to the medical doctor. I do maintain a relationship with my PCP. I'm seeing her next week, but that's the soonest that I can get in. So I stand again today in support of anything we can do to expand the scope of practice, formularies, whatever we must do for our NDs. They are a very, very professional group. They work very closely with the medical community. I would never do anything without consultation with her and with them combined. And it's been a wonderful relationship. So to that end, I stand and again ask all of my colleagues to support this. Thank you.
Thank you.
Any questions?
Questions from committee members?
Thank you all.
Seeing none, thank you. And anyone else in the room wishing to testify in favor? Right, we do have some people online. Edna, if you want to move Deborah over. Oh. Okay, Deborah, we can see you, but you're sideways.
Oh, sorry.
There we go. Thank you. You can go ahead whenever you're ready.
Sorry, I'm over in Oregon. I just got out of the mountains. That's why maybe I'm feeling a little bit sideways. So just wanted to say that thank you for the committee members to allow me an opportunity to speak. I
If you could
graduated from
just say your name before you start.
Oh, sorry. I'm Dr. Deborah Moskowitz. I practice in Camden, Maine.
Thank you.
And I've been practicing naturopathic doctor for 30 years. I started my practice in Oregon, and I practiced in Oregon until 2009 when I moved to Maine. When I practiced in Oregon, I had pretty full prescriptive rights. I also had a DEA number, which is a specific registration in order to be able to prescribe scheduled drugs. The one that I prescribed probably most often was testosterone as a part of a hormone replacement therapy. I didn't prescribe it a lot, but when it was needed, it was very important. When I moved to Maine, I had a more restricted scope of practice, and there would be times that would come up with I would want to prescribe testosterone, and I ended up having to refer my patients to their primary care, and actually often the primary care really didn't understand how to prescribe testosterone as a bioidentical hormone. And so I would literally walk them through what the prescription was so that they could prescribe it. Naturopathic doctors get a lot of education on hormones and pharmaceutical agents, and so many times in the state of Maine, I felt like my hands were tied in not being able to prescribe certain medications that were incredibly important. There are multiple times when a patient came in to see me, hadn't been in to see their primary care for sometimes years, often because they lost their primary care doctor because their doctor retired. They couldn't get in to see anybody else. And when I take their blood pressure, they had very high blood pressure and they were coming in maybe for a headache or just feeling unwell. And I couldn't prescribe metoprolol. I couldn't prescribe some of these very basic antihypertensives that would have easily gotten my patients out of the danger zone. But instead, I'd have to say, now I need you to go to the emergency room. You need to get this prescribed. And one time I even offered to drive the patient to the emergency room because I didn't think that they would go. I thought they would just go back home because they were really reticent to have that cost. I have a lot of patients who don't have health insurance and they pay out of pocket. And metoprolol and some of the other antihypertensives, they're not expensive.
Okay, I'm not sure if you can see the clock, but your time is up. If you could finish up. Yeah.
Yeah, so I just wanted to say I would very much like the current rules to be approved as written. I think it would provide much more safe care for Mainers who need access.
Okay, thank you. Thank you for joining us. Questions, Representative Clucci.
Thank you, Madam Chair. Thank you, Dr. Moskowitz. You are on the board, right, and helped together these rules. So I have just a couple of additional questions, if possible. One is, I don't know if you've been listening the whole time, but I'm curious what additional sort of medications or sort of groups of therapies have been added that are going to sort of allow you to better, practice your medicine. I heard antibiotics, which seems like that's a clear issue, diabetes medications, blood pressure medications, but what other?
Sure. Did you just mention your asthma medications? Because that comes up quite a bit. So I practice, I treat a lot of Lyme disease, which is very prevalent in Maine. Sometimes it's necessary if somebody has, say, an allergy to a certain medication, like doxycycline. I might need to prescribe something else. I know I'm limited right now in being able to prescribe any of the ciprofloxacins. So that's a missing one. Sometimes, actually, I had a patient come in last week, being treated for Lyme disease, 2-tiered positive tests, so qualifies for a diagnosis of Lyme disease per the CDC, and yet he is a builder, and his hands were so swollen he could barely close his hands. Now, he would have very much benefited from, say, a stepwise approach with prednisone, a 5-day ramp up, ramp down, and that would have completely taken care of the pain that he was having, his inability to literally even grab a tool. He was already under care for the Lyme disease, but I had to tell him he'd have to go back to his primary care in order to get that prescription. He wasn't able to get in with his primary care, so I said, well, you could go to the emergency room and try to get that there. The emergency room referred him back to his primary care, of whom he couldn't get into. And meanwhile, this man is suffering. I offered, ibuprofen. I offered icing his hands. I gave him lots of things to do that would just kind of take the edge off. But really what he needed was a 5-day prednisone prescription, which I had prescribed plenty of times in Oregon. I knew how to do it. It's an easy prescription. And most primary care doctors and family medicine doctors prescribe it. I was hampered. I could have addressed his care much sooner.
Further questions? Representative Arford.
Thank you, Madam Chair, and thank you for being here with us. On this, because you seem to be quite knowledgeable in this, number F on our list of red items that are being added now, medical appliances and devices that do not require major surgical intervention. And it appears that prior to this, you weren't allowed to subscribe or offer these to patients. What are we talking about here?
Oh, so I have a lot of young female patients who, for whom oral contraception is somewhat problematic. So I often recommend IUDs. It's pretty easy to get trained to put in an IUD, and it often is much more effective as contraception because you're not forgetting to take pills. And some of the IUDs have very little hormonal impact, so you don't have the side effects of undulating hormone levels. We know that nurse practitioners and some just certified nurse midwives all can insert them. That would be one example of something that would be really quite helpful.
And my other question would be, so if this was to pass, if these rules were to go into effect, then the situation you just talked about with the gentleman with the swollen, very painful hands, what would you have prescribed at that point in time if these were in effect?
Oh, I would have prescribed 5 days of prednisone.
And okay, and eventually did he get that prescription from another provider?
I don't know. This was just from last week, and I think what I ended up having him do, and like I went on vacation, but I have a nurse practitioner who practices in my office. I texted her and said, "Could you fit this gentleman in?" And I'm not sure where that was because at the time she was out of the office, so it was a text message. I just got back out of the mountains. I've been without computer or anything but my phone. I only just got back into cell service land.
Okay, and thank you very much. I really appreciate you being here and speaking with us.
You're very welcome.
Representative Clucci has another question.
Thank you, Madam Chair. So, as part of the rules, it looks like the one part that will carry over that's not changing is that if you're new to a new ND in Maine, you'll still have to enter into a 1-year relationship. Can you just talk to me about like what does that relationship look like? How do the NDs find the person who's willing to do this? Like, is it just a few people across the state that are willing to do it and they do it for everybody? Like, just help me understand, what does this like look like?
Sure. So I was lucky when I came to Maine. There was a naturopathic doctor who had a practice for 2 years, and she gave me the lowdown on who the MDs were who were open to having a relationship with NDs. And so she gave me the name of Dr. Deborah Peabody. And so I called Deborah Peabody, and she agreed to enter into this relationship to look at my prescribing. And it actually led to a really lovely relationship with this medical doctor, not only Deborah Peabody, but also Mary Ashmore in my community. And they were very interested in naturopathic medicine. And I remember one of the first conversations I had with Deborah Peabody where she was asking me advice for a patient she had. And she said, I like the way you think. Because it was a little bit different than how she had been taught in terms of treating a disease as opposed to treating the underlying cause, the sort of the system that was affected. So I lucked out, but I've had other NDs when they came to Maine say, "Who did you use?" And Deb Peabody, I think she is either really close to retiring or about to retire. So I do think it's a little bit harder. But the more time the naturopathic doctors are engaging with the medical doctors, the more they understand how we practice. So now, after being here since 2009, I have a good relationship with a lot of different medical doctors and nurse practitioners and nurse midwives, and we can be collaborative. I see medical doctors as patients. They refer their patients to me. So, I mean, I think that the doctors who come to Maine, the NDs who need to have a collaborative relationship, they will find them. I think it would be great to have NDs be able to be that collaborative relation in order to have that 1 year oversight, because we have more and more naturopathic doctors who have been here and who have been providing prescriptions to patients. And we do have the unique understanding of how a lot of medications interact with herbs and nutrition and so forth. But that would be a statute change.
Yeah, so thank you. So was there any discussion when you were among the board when you're thinking of expanding and to opening up to, it seems like a decent amount of new classes of medications? I mean, I'm trying to, I mean, this is the question I keep answering, is like, how much are we actually expanding this? But what I'm curious, was there ever a constant consideration, like, how do we make sure that the existing NDs get the adequate training needed to now prescribe all this new stuff that they're going to be able to prescribe?
Okay, so they already got the training in medical school. And let's say that a medical doctor learned about the existing medications when they were in medical school 20 years ago. How are they going to get the additional information about new medications? The same way we do. They get it from drug reps, and they come and visit their clinics. They get it from going to conferences. We have to have, a minimum of 7 hours of pharmaceutical continuing education every single year. I often have way more than that for my CME each year. So no medical school, whether allopathic or naturopathic, is going to cover all current and future medications that might come up. And so one thing that the medical doctor who is a part of our committee who worked on this, when she saw that we had just a list of pharmaceuticals we could prescribe, she said, "Why is that?" She said, "I can prescribe anything I want." She said, "I wouldn't necessarily prescribe anything, but I don't have any restrictions, even though there are things that I haven't learned about." So she thought it was kind of odd. Same with the nurse practitioner who works with me. She doesn't have any restrictions on what she's able to prescribe. Would she prescribe something that she wasn't familiar with? No. We're self-regulating, and they are self-regulating. And so other types of providers, PAs, NPs, certified nurse midwives, they don't have those restrictions. And the medical doctor who worked with us was completely in favor of a pharmacy of exclusion, because it would be something that would grow when there are new medications that came about. How could you possibly predict what is going to be, the new and appropriate drug that is, available?
Further questions? Representative Arthur.
Thank you, Madam Chair. I need your help with this. I've been sitting here listening and we've been given excellent information. Thank you all very much. And this is what I've heard, and I want to make sure, my question is, did I get this right? That in actuality, the scope of practice that your training, your 4 years of training prepares you for already included all the medications that we now are going to add in our state rules to allow you to prescribe. But your scope of practice already allowed for that. It's just that main rules, I should say, did not allow for it. So that's why we aren't real. I was trying to figure out the scope of practice, the rules relationship. And so am I correct in understanding that this is in fact not a scope of practice expansion? It's an expansion of what you can prescribe that is already covered under your scope of practice. And now the rules are actually, if you will, expanding to allow you to prescribe them. And is that an accurate summation of all this? And if I didn't get it right, please correct me. I really would like to be corrected.
Exactly. You are exactly correct.
Thank you very much.
And we were also trained in controlled substances.
Okay. Further questions? Seeing none, thank you for joining us.
Thank you.
Edna, could you move over Grace, please, if she's still there? No. There she is.
I think you might have said.
Who do we have?
We have Jared.
Oh, yeah, we apologize.
I'm sorry, that should be there.
No. We will get to you in a bit. Thank you. All right, we do have Grace down below, though. Grace, I think you need to unmute yourself. There we go.
Yes. Hi,
All
can
right.
you hear me?
Yes, you're all set now. Thank you.
Okay. All right, I'm Grace Abbott. I live in Portland. I grew up in Freeport, and I'm speaking today to express my strong support for the proposed naturopathic formulary. Expanding prescriptive authority for NDs is essential for patients like me who rely on them for comprehensive health care. I've had the same doctor since I was born. She spoke earlier today, Dr. Ackerley. She's a very experienced naturopath who I literally trust with my life. Dr. Ackerley has continued to provide attentive and expert care throughout my childhood and into adulthood. I trust her with prescriptive authority because of her extensive knowledge and training in both natural remedies and pharmaceutical medications, including their potential interactions. I've had asthma my entire life, and my doctor cannot prescribe me my rescue inhaler currently, which she would be able to with this proposed formulary. This year, I had to wait months for an appointment with an asthma specialist in order to get my inhaler prescribed to me. For me, it's an inconvenience at best and a serious difficulty at worst. I have to make separate appointments and pay separate costly bills to meet my basic health needs that I should easily be able to get from my very experienced naturopathic doctor. As was already mentioned, Vermont and New Hampshire have already expanded ND prescribing rights to include prescribed medications like my albuterol inhaler. I incorrectly wrote in my written testimony that it's a controlled substance, but it's not. And so I need this inhaler to prevent asthma attacks and ensure that I can breathe. And my doctor has the proper training to provide this essential service. These challenges are even more difficult for Mainers who may not have access to a personal vehicle or the time to schedule and attend multiple healthcare services that could easily be combined. What can be an inconvenience for me can be life or death for others. Waiting to get off long wait lists is not an option for many Mainers who face health emergencies more urgent than I do. I hope to continue to receive naturopathic care from my doctor long into my life. Approving these guidelines will allow me and other Mainers to do so more safely and with fewer barriers to our essential health needs. I respectfully request you approve the rules as written. I don't see the time, but if I have additional time, I'll just add that yeah, it seems like there might be misunderstanding or misinformation about what naturopaths have the knowledge to do. And I would say that all of my experience, my whole life with my doctor has been nothing but, as someone kind of explained, almost like a detective work where I can tell that she really tries her hardest to get me the best care possible. And when that means referring me to other doctors and specialists as needed, she's more than happy to do that and provides me with a plethora of options because of her specialization in naturopathy, and to be able to continue to see her for all of my needs, including my asthma needs, makes the most sense for me and would make a big difference in my life. And that's why I'm supporting this formulary. Thank you.
All right, so thank you. Thank you for joining us. Any questions from committee members? I'm not seeing any. Thank you very much.
Thank you.
All right, and if you could move Joseph over.
Okay, can you all hear me?
Yes, we can. Go ahead.
Okay, so I have submitted written testimony, but rather than read that, I'm here to strongly support the proposed rules as written. There, I've looked.
Could you just state your name, please?
Sorry, my name is Joe McHugh. So I'm a
Thank you.
primary care osteopath in Central Maine. I own and run a direct care practice in Kennebec County. And I have spent my entire private practice career working with and alongside naturopathic doctors. I've attended conferences that MAND has put on. I have consulted with naturopaths and for naturopaths. I collaborate with patient care very regularly. And, quite frankly, I have probably learned more about the treatment of chronic, systemic, complicated disease that gets dismissed from naturopaths than I have taught any of them. And I think that this is a formulary update that is wildly overdue. And when I first started practice, part of the services that I would provide to patients was to collaborate with their naturopathic physicians who were already managing things and knew very clearly what they needed to do, but didn't have the prescriptive authority to do it. Who clearly understood the pharmacology, who clearly understood the indications, the safety parameters, the interaction potential. And frankly, we find ourselves as osteopaths and allopathic physicians in a place where we're trying to inject into our medical education system and into our board testing and things like that, the components that naturopathic medicine does right out of the gate. We don't learn nutrition. We don't learn anything about the herbs that get used or how they get used or their efficacy or any of those things or any of their interactions. We don't learn much about preventative healthcare in any kind of a real way. And those are all places that we're working to do better, and that naturopaths are already doing, aside from their in-depth pharmacological knowledge. So, you know, for me, this is a no-brainer, and I very strongly urge that this moves forward. I don't see any of the proposal that looks like anything other than what should have been in place 30 years ago when the initial recommendation was made for something very similar to the way that the formulary proposal is written.
Okay, thank you very much. Questions from committee members? Not seeing any. Thank you very much for joining us. And at this time, just one last call. Anyone who wants to testify in favor? Okay, if not, then we will move on to anyone in the room wishing to testify against. Not seeing any. We do have some people online. If you could move Jane over, please. Welcome. You're all set whenever you're ready.
Okay, thank you. Senator Bailey, Representative Matheson, members of the Committee on Health Coverage Insurance and Financial Services. My name is Jane Pringle, MD, and I live in Wyndham. I'm here to submit testimony in opposition to LD 2242, a resolve regarding legislative review of portions of Chapter 6. I worked as a primary care physician in general internal medicine for 36 years, including as a program director for an internal medicine residency program. I, along with other faculty, had to assess resident competency and certify that residents were competent to practice and perform procedures upon completion of residency. This was in addition to their passing specialty board certification examinations. Also, to maintain their licenses, physicians are required to complete continuing education from approved institutions or organizations deemed qualified to issue this training. Also, to add a procedure such as bedside ultrasound to my clinical practice, my professional organization, the American College of Physicians, offers courses that allow me to become competent in this procedure. I recognize that the healthcare landscape has changed significantly, and I fully appreciate that naturopathic doctors have helped fill the gaps for our shared patients. I fully recognize that it is much harder to access healthcare today, but I do not believe that lowering training standards is the appropriate path forward. A good model to support team-based care across specialties is the Working Group to Improve Rural Obstetric Care. They have convened representatives from the various provider organizations, obstetrics and gynecology, family medicine, midwives, nurse practitioners, and EMS folks. They are looking at systems including telehealth to improve outcomes for pregnant women. I will share an example to illustrate my point. Allowing NDs to quote, use, prescribe, dispense, and order via any route of administration, medical appliances and devices that do not require major surgical intervention, end of quote. This could include contraceptive devices like IUDs, which we already heard mentioned, which have recently gained important recognition for being a device that might require general anesthesia, given the pain that it can cause women when inserted. But the vagueness of the line means that it can include much more. and I believe the role should be limited to procedures that can match the universal training in their programs. I would like to share that I have great empathy for the many people who've testified that our healthcare system has lots of problems, and that we do not have enough resources. And I fully understand the doctor-patient relationship that the patients have expressed. When you have someone who cares about you, we know that that's a very important part of people getting better, is having belief in the provider and what they recommend. But I do believe that we cannot give up science-based, we cannot live on anecdotes. We have to look at placebo-controlled studies and the scientific literature and organizations that are equipped nationally to provide continuing education and certified competency. Thank you. I would be happy to answer any questions you have.
Thank you. Questions from committee members? Representative Morris.
Thank you, Madam Chair. Good to see you, Ms. Pringle. I did have a question though. If a former member of this committee testifies remotely, are they still required to send a tribute?
I was wondering the same thing.
Okay, I thought I'd say that.
I started
It
to
is good to
think
see
that I
you,
should
Jane.
tell you I will FedEx a few goodies to the committee. But I need to know what you're wanting to eat these days.
Representative Clucci, I think, might have a real question.
Thank you, Madam Chair. Thank you, Honorable Dr. Pringle.
Welcome to call me Jane.
Something that I would value understanding is what kind of pharmaceutical training and pharmacology training do you get through those 7 years or those 3 to 7 years of residency that better prepares you to, I'm just like curious, like what is the, you're through those residency programs, presumably in addition to like doing inpatient, hands-on stuff, you're working with medication. So what training specifically over that residency period focuses on pharmacology?
Okay, well, many of the teams today in residency programs include a clinical pharmacologist or a PharmD who may be part of the team, who often will review records for patients that are scheduled for visits or are available to consultation with an inpatient team that's making rounds on a patient. Also, the pharmacies always got available the pharmacist who can do a consultation for you if you have difficulty obtaining a certain drug for a patient or a therapy, and you want their help finding one that may be more cost-effective or affordable. So you get basic training in pharmacology in medical school, and as was pointed out, education now is much more integrative, so that often you will get your cardiac drugs on your cardiology rotation or your cardiology part of the syllabus for your basic sciences in medical school. But the access to education and use of a pharmacist in your team is always available. I think even in some of the private practices, access to speaking with the pharmacist at any pharmacy is available when you, as you know, the various pharmacies will now look at various programs that will help people access their medications when they can't afford them. I'm not sure if I answered the question that you had, but.
Any further
There's
questions?
continuing education too. Yeah.
Right, Representative Arford.
Again, first of all, thank you, Madam Chair. I would like to thank you and acknowledge what a pleasure it is having you here with us today, Dr. Pringle, and also my having served with you previously, my respect for your opinion on things and the information you're providing us with. So I have a question for you. This year, we've had a number of the different professional groups come before us for a number of different things. And specifically physician associates. Am I correct in thinking that what you just talked to us about, you're you were talking about naturopaths and MDs, correct? Or DOs? And the education and the residency requirements that were placed upon that group of providers, the DOs and the MDs, is that correct?
Yes.
So I just want to ask you about the physician associates. It's my understanding, and I may be wrong, that in fact, when their scope of practice that they're licensed into after 2 years of medical school covers all the items that these new rules for the NPs would allow the NPs to do. I'm not the MP, naturopathic NDs. Is that correct?
You know, I'm not, I can't answer that. I'm not that familiar. My understanding is most physician assistants up until recently, I think maybe there's been a change, are required to have a supervising physician. Most of the physician assistants that I'm familiar with usually work with a surgeon, and usually their licenses supervised by that person. But I heard more recently that perhaps they've been allowed to do independent practice, such as nurse practitioners. And
Right.
I am not aware of what the current licensing requirements or continuing education requirements are for them. So I'm sorry, Poppy, I can't answer your question.
Well, thank you very much. And it's really good to see you.
Okay, further questions?
Likewise.
All right, I'm not seeing any other questions. Thank you for joining us. Always good to see you.
Yeah, thank you very much.
And-
Likewise.
And if you
Bye-bye.
want to move Garrett over. Welcome back, whenever you're ready.
Not Grace this time. Good afternoon, everybody. Senator Bailey, Representative Matheson, and members of the Committee on Health Coverage, Insurance, and Financial Services. My name is Garrett Fontaine, MD, and I am a family medicine physician and also the co-chair of the Legislative Committee for the Maine Medical Association. I am submitting testimony to you today in opposition of this bill, LD 2242. On behalf of the Maine Medical Association, the Maine Osteopathic Association, the Maine Academy of Physician Associates, the Maine Pharmacy Association, and the Maine Society of Healthcare Health System Pharmacists. Apologize. I believe my unique background affords me a bit of a nuanced view in this. I split my time between 5 different roles. I work at a college health clinic, a general primary care clinic. I precept family medicine residents, preparing them to become independent family physicians. I work at a migrant health clinic, and I work at a free clinic for people who are homeless in the city of Augusta. As a primary care doctor, I work in an underserved area here in central Maine. And I dedicate a huge amount of time to recruiting well-qualified physicians who want to come be family docs in Maine to the place that I work at. Given the profound impact of what we're talking about here, I recognize the importance for increasing access to patients, but I do want to maintain a high quality standard and keep that as a central priority. Last year, the MMA and MOA presented testimony on LD 1128. And since the legislature first recognized and regulated naturopathy in 1996, NDs have continued to seek to expand their scope of practice and the formulary in this case. We have opposed these efforts, not because we don't value our partnership with NDs, but because their training differs significantly from the education that physicians and advanced practice clinicians go through. After this committee determined it was more appropriate to seek rulemaking changes, we engaged in a lengthy process to gather member feedback and considerations about these proposed rules. We partnered with the Maine Academy of Physician Associates, Maine Pharmacy Association, Maine Society of Health System Pharmacists on the comments, and have attached those comments to my testimony here. We have not yet received a formal response to our comments, but comparing the proposed and provisional adopted rules, it appears that none of our feedback was incorporated, and the only change that I'm able to see is that offered was changed to approved in section 4C. Since the rules are essentially the same, we would request that our testimony be read in conjunction with the testimony I'm presenting here. I'd like to bring up two specific concerns that I have. I see my time is running out. Could I just briefly hit on those 2 points?
Yep, briefly. And if we do have your testimony, I assume, right? Okay. But go ahead, you can briefly hit on your 2 points.
Absolutely. So the first would just be the difference in training. As a physician, I received 12,000 to 16,000 hours in training. 9,000 to 10,000 of that was in a residency program. By our read of the handbook, naturopaths require no residency and must complete 1,200 hours of clinical training, 850 of which is in direct patient care. And as previously highlighted by others that testified, we don't see any specific requirements for pharmacology or described curricula. And in our search across the different schools' websites, I do not see a consistent set of standards for pharmacology. I would highlight as my primary concern as a physician. We learn a huge amount in residency, and while I'm not a naturopath, I'm sure the same is true for their training. But the value of going through a residency and core clinical rotations during medical school and residency gave us the experience with a safety net, with an overseeing physicians, to have that sort of spaced repetition of learning how to provide these medications to folks for diseases in a way that was able for us to go out in independent practice and practice safely. My concern would be if this formulary is an expansion for folks and the schools are not training folks with this expansive formulary, that someone may come out of their schooling without specific experience and that sort of spaced repetition that's needed for learning that we so emphasize in family medicine training.
Okay. Questions? Representative Boyer.
Thank you, Madam Chair. Thank you, Doctor, for being here. Can you just help me understand? We heard some testimony that naturopathic doctors can prescribe insulin, but they're not allowed to prescribe that first line of defense, which I'm sorry, I have no medical background, so I don't know what that's called. Can you help me understand that? Because I'm really, that just seems weird to me.
Sure. Yeah, I would agree. And I would say, so the really important point is the insulin is generally indicated for a specific type of diabetes, type 1 diabetes, or folks that have type 2 diabetes that is severe. For type 2 diabetes, which is, this is oversimplifying, but more of a problem of resistance to insulin, not making insulin. We generally have other medicines that we prescribe for folks. You wouldn't generally start with insulin unless the diabetes was really bad.
Yeah, I guess so. That's what I'm trying to understand. Currently, as I understand it, naturopathic doctors can prescribe insulin, but don't have the ability to prescribe that first line of defense. And I was hoping you could help me understand, because you talked about safety being a concern. And so I'm just trying to reconcile that in my head.
Yes, and I agree. Listening to the testimony earlier that insulin is a high risk medication, I certainly agree with that. And I think I would say that experience with practicing with these medications is really important. And so I'm not familiar with sort of the logic behind their formulary. All I can speak to is the fact that, almost all diabetic medications a lot of experience, and caution is really important.
Further questions? Representative Clucci.
Thank you, Madam Chair. One of the things that we heard during the rulemaking, when the rulemaking process was discussed, is that there was an attempt to try and get some pharmacist feedback. And what we heard from the board was that the members of the pharmacy board didn't provide any. You are testifying on behalf of 2 pharmacy groups. Can you provide some more specifics about the feedback you heard from the pharmacy groups?
So sort of my comments are the distillation of those comments from the pharmacy groups. I can't comment on sort of the exact comments that were boiled down, but I would be happy to get back to you after I talk to the folks that sort of compiled things.
Further questions? Representative Clucci.
Thank you, Madam Chair. And then, so on the diabetes example, so this is what I'm curious about is, so it seems like if insulin was not a good first line medication, then I would imagine that the NDs are not currently really sort of managing all aspects of diabetes care for patients with care. So if they're now having access to be able to prescribe all of the diabetes medications, wouldn't that be sort of opening up an additional sort of field of medicine that they're now sort of managing diabetes and sort of doing the functions of an endocrinologist, and therefore isn't that like expanding scope, or are they already trained to manage diabetes and medication, adding medication to it is just a tool?
Yeah, so while insulin, you're highlighting an important point. Insulin is certainly a cornerstone, but sort of the finesse behind using the oral and injectable medications, especially the newer ones, is definitely something that we as family physicians in Maine do. Certainly a lot of that care is in consultation with an endocrinologist when available, but that's not always the case. So I guess in terms of getting to the crux of your question, I don't know that I would say an endocrinologist would necessarily need to be involved in prescription of pill forms of diabetes treatment. And actually, the more common scenario for family practice is when someone has type 1 diabetes and has difficulty controlling for management of their insulin through something like an insulin pump, or with use of a continuous glucose monitor, which does require a lot of finesse and extra training.
Representative Arford.
Thank you, Madam Chair. And thank you so much for being here with us today. It's really important that we're getting a very well-rounded view of people's opinions on these particular rules. And my question for you is, you've made a number of comments about, and by the way, I don't disagree or agree with anything you've said, but you've made a number of comments about how physicians like yourself, are able to prescribe a number of different things. And you've alluded to the fact that you do not feel it would be at all appropriate for a naturopath to be able to prescribe those same products. However, my understanding of the rules is we're still getting a very narrow opening or expansion, or whatever you want to call it, through these rules of pharmaceutical products that a naturopath would be able to prescribe. It's nothing compared to what you yourself currently are able to prescribe. There's still a lot of items left off of these lists. And so I'm just going to ask you to reflect back on these rules, which I'm sure you have looked over these rules. And you may not be able to answer this right now, but if you or another person representing the folks that you're representing could allude to the fact there's like an A, B, C, D, E, F, G, H on the first page of the rule that present to us what products, if these rules were to pass, naturopaths would be able to prescribe. I would be very interested, because this is all new to me, of those like 1, 2, 3, 4, 8 items, which items specifically based on your medical training and knowledge and experience, in your opinion, do you not believe would be appropriate for naturopaths to be granted prescriptive authority, which these rules would do if they were passed? I would love to know which one of these items you specifically have an issue with. And if you're able to do that, I would personally appreciate it.
Yeah, I don't have the rule in front of me. I'm trying to find it on my desktop here. But I would just give sort of a few examples from, we've talked a lot about medicines for high blood pressure, as well as medicines for diabetes here. And so one thing that I would highlight is that we universally get a significant amount of inpatient training. And I think one of the things that we're told as we're doing that inpatient training is it's important to have that perspective as you are, even if you're not going to practice inpatient medicine afterwards, to understand sort of the end stages of the diseases that you're treating and understand sort of the trajectory of the medical treatments that you're prescribing. And so I feel that that is a very important, essential piece of training. And without that, I don't think that I would feel well prepared to practice. If you are looking for a few examples, one, if we're picking a blood pressure medicine, something say as common as losartan. The way this medication works is it essentially alters the amount of blood flow that's getting to the kidney, and helps you regulate the blood pressure in your body through that mechanism. These types of medications, while they may appear benign, can be incredibly toxic to the kidneys in the wrong circumstances. And so my concern is if you haven't had the experience using those medications on repeat via clinical hours in medical school and residency, you may not have sort of the foresight to understand the complex interplay between these medications that you're prescribing and the sort of complications that may come from prescribing them.
Thank you very much. Really appreciate your testimony.
Further questions? Seeing none, thank you for joining us.
Thank you.
And if you could move over Amanda. Hello, welcome. Whenever you're ready, go ahead.
Okay. Can you hear me okay?
Yes, we can. Thank you.
Senator Bailey, Representative Mathiasen, and members of the Committee of Health Coverage, Insurance, and Financial Services. My name is Dr. Amanda Cardella. I'm an osteopathic physician practicing in Maine. I'm submitting this testimony in opposition to LD 2242, which we've already discussed the name of. I want to acknowledge that many clinicians, including myself, value the role of the naturopathic doctors play in patient care. I have actually shared several patients with Dr. Sarah Ackerley because I work in Topsom and Brunswick. This testimony is not about limiting access or diminishing that role. Rather, it is about ensuring the scope of practice aligns with education and training, and that regulatory frameworks prioritize patient safety above all else. I won't speak to the training for the naturopaths because that's already been discussed quite a bit. I will say that I would like you all to understand what my training is. And so I went to DO school for 4 years and then went to family medicine residency for 3 years. What happens during residency is you generally have an intern year where you work in the hospital primarily. And then I also worked in the office under a preceptor. In the 3 years in primary care residency, I was assigned patients. That amount of time would increase in the office as I moved forward in the program. So the first year I spent a lot more time in the hospital, seeing what severe disease looks like, being exposed to surgery as well as dialysis and emergency room, admitting patients, and working with all of the different specialists that work in the hospital. Having had that experience informed my treatment in outpatient care. I would call myself a very, well-versed physician in regards to diabetes and high blood pressure treatment. And like Dr. Fontaine said, I don't feel that I would be comfortable with all of the complications that could happen from those medications if I hadn't worked in the hospital. And also the 3 years that I worked under a preceptor who would not just look at my notes, but I would have to, so you would see your patient in the office and then you'd have to go into another office and describe everything that happened in the encounter, go over the plan with your preceptor, and then go back and do the care with the patient. As you progress.
I'm not sure if you can see the clock, but your time is up. So if you could wrap up, that'd be great. Thank you.
Okay, so I would like to comment on the language in the documentation regarding peptides and amino acids. I'm hoping that I can have a few more moments to discuss that as no one else has spoken about it.
That is fine. Go ahead.
Okay, so if anyone has any questions about my training, I'm happy to answer those questions. So I want to flag a piece of language that may be easy to overlook, but it to me is especially concerning. The specific reference to the inclusion of peptides and amino acids. In practice, the word peptides, especially in the last few, or I would say the last year and a half, often refers to substances like GLP-1 agonists for weight loss and compounds such as BPC 157. Many of these are marketed through alternative or longevity practices and are not FDA approved. Some are explicitly labeled for research purposes only, yet patients are accessing and using them as if they're standard medications. This is a rapidly growing and largely unregulated market. I've had patients bring in these products purchased online or administered through infusion clinics, believing they are safe because they are offered in clinical setting. In reality, many of these substances have not undergone the scientific rigor required to establish safety, efficacy, dosing, or interactions. As a physician, I was trained to critically evaluate scientific evidence and to be cautious about adopting new therapies that have not been adequately studied. There have been recent warnings from manufacturers like Eli Lilly regarding GLP-1 medications being added to vitamin B12, causing new chemical properties. These are not theoretical concerns. They are emerging safety issues in real time, and I've made a deliberate decision not to prescribe these medications and non-FDA approved substances because of these risks. I'm concerned that this proposal creates an opening for expansion of this market without the training, oversight, and evidence base needed to protect patients. I also made a comment in my testimony about lithium, but I do think that that was somewhat addressed earlier, and I would just like a statement added that the particular type of lithium that is allowed to be prescribed and not the lithium carbonate or citrate that is generally referred by psychiatrists or neurology fields. Many PCPs won't even prescribe that.
Okay, thank you. Questions from committee members? Representative Clucci.
Thank you, Madam Chair. Thank you, Dr. Cardella. On the peptides, does the formulary expansion allow for NDs to request compounded medications be created?
you're asking, what was the question again? I'm so
Well,
sorry.
I'm just trying to understand, like, the situation you mentioned about, people coming in with drugs that had been compounded that hadn't necessarily been FDA approved. Like,
Yes, I think so, because the comment that one person made earlier was about the compounding pharmacists at Coastal Wellness. So I think it's common practice to prescribe compounding medications.
okay, thanks.
Further
And
questions?
I think we should have comment about that in this document.
Further questions? Representative Coochie.
What would that comment be?
I think that there should be specifics rather than the generalization that's in the document. So that I, again, don't have the document right in front of me, but I remember it saying peptides and amino acids and several other kind of more generic terminology. I think if we're expanding the formulary, there needs to be clear guidance as to not prescribing things that are not FDA approved.
Further questions? Seeing none, thank you very much for joining us. And Edna, I think that's everyone we have online, right? Okay, so once again, anyone in the room wishing to testify in opposition? Anyone wishing to testify neither for nor against? Seeing none, I will close the public hearing on LD 2242. Any request for Colleen for the work session? Representative Boyer.
Thank you, Madam Chair. Colleen, maybe it was said, but I missed it. How many naturopathic doctors are licensed in Maine? 40, like 40.
I think in Penny's testimony.
Is it in Penny's testimony?
She says 89 actively licensed.
Oh, thank you, Madam Chair. Thank you.
Yep. Anything else? Representative Chimino.
Thank you, Madam Chair. Colleen, could you also check and see if anything on that list is not approved by the FDA? Thank you.
Representative Clucci.
Colleen, it says under when I asked OPOR for information about licensure, I think that they said that the naturopathic colleges had to be accredited, but then the language in the statute says approved. So I'm wondering, is there a difference between those two?
Okay. Think further. Representative Arford.
Thank you, Madam Chair. Yeah, we may have it in here, but I don't know exactly where it is. Did we have any charts or comparative information when we first heard this bill that talked about what's happening in other states with naturopaths and prescriptive authority? Because I'd love to see a comparison of exactly what they get based on this, because this now is pretty specific in terms of what what the rules would allow. And I'd be very interested in knowing, and you may not be able to do this, but whatever you can find out about in the states that allow naturopaths to have prescriptive authority, what are the rules? What could you tell us about that?
Okay. Anything else? All right, that's it for 2242. Look at that. We've already moved I was going to say, we probably need a moment to get things ready for the work session, but people are fast around here. So we will open the work session on LB 2233.
Thank you.
Did I miss something?
No.
The thing that Colleen says has.
So do you have a favorite color for the
Yes.
different colors we got?
I'm not sure.
Okay, I think blue is my favorite color.
I don't like it. How about you?
Like, do you know
Does
what?
stand out.
Yeah, I know, but it's
I
almost too
don't,
much.
I don't think so, but let me check.
I know, Well, do we have copies in our, oh, yeah, it's right here. The thing that you sent us.
All right, we all set? Great. Yes.
So Edna distributed on blue the analysis for LD 2233. This is the bill that the committee put forward based on the recommendations of a working group to combine the Board of Licensure of Medicine with the Board of Osteopathic Licensure into a single licensing board for all physicians and physician associates. The bill has two parts. Part A of the bill is the statutory language to combine the boards into a single licensing board, known as the Maine Board of Medicine. It has an effective date of January 1 of 2027. Part B of the bill requires the Board of Licensure of Medicine and the Board of Osteopathic Medicine to report next session on the planning completed by the board prior to the effective date of the Maine Board of Medicine, including recommendations for any additional suggested legislation necessary to further implement the merger. They're required to submit that report both to the governor and the Joint Standing Committee having jurisdiction over professional licensing board matters no later than January 31 of 2027. And then the language of Part B also would authorize the committee to report out a bill on the based on the report to the 133rd legislature in 2027. As I think you know, the draft was originally presented to the committee based on the recommendations of the working group. So I worked with the revisor's office to use that draft legislation as the basis for putting the bill forward. And I think the bill sought to just incorporate all of the provisions in current law and move them forward into combining the boards, although there were a few places identified in the committee, in the working group report to the committee where the board made some recommendations for additional changes that the committee did incorporate. But there were a number of suggestions for the committee made at the public hearing about the language of the new that would govern the new Maine Board of Medicine, and they're outlined for you in the analysis. One of them is the deletion of a sentence in current law that addresses or includes language related to religious practices and administration to the sick or suffering by mental or spiritual means. In current law, in the that governs the Board of Licensure Medicine, in section 3270, which is attached for you on page 4 of the blue bill analysis, there's a sentence at the end of that second paragraph that says nothing in this chapter may be construed as to affect or prevent the practice of the religious tenets of a church in the ministration to the sick or suffering by mental or spiritual needs. That sentence was not carried forward in the draft language that was prepared by the working group, so it wasn't included in LD 2233. You did have written testimony that was submitted to the committee on behalf of the Christian Science Committee on publication for Maine, requesting that the committee amend the bill to add that language back in. This is language that has been in statute since 1973. So since the Board of Licensure in Medicine was created in statute, that sentence has been in there. And they've asked for the committee to consider putting that back in.
Representative Clucci.
Thank you. I just want, what does that mean?
So essentially, it means that if someone is, that the licensing chapter can't be construed to, that if someone is ministering to the sick using their religious practices by mental or spiritual means, that should not be construed to be the practice of medicine requiring a license.
Oh, so they can just.
So it protects their religious practice. That's the intention of that language. It does appear in other sections of statute. There is a section in Title 24A, for instance, related to in Chapter 56A, which is the Healthcare Bill of Rights, related to patient protection, that has a similar sentence that this chapter may not be construed to affect someone's ability to follow their religious practices.
Great. Representative Stracchio.
Thank you, Madam Chair. So leaving it in, out, putting it in, Colleen, like, does it change anything? I mean, what are the chances that a medical board is going to actually, if somebody says, I want my minister to come in and pray over me, I mean.
Yeah,
I
I
don't
mean,
get
I
it.
think it's a policy decision of the committee as to what effect that language has. I mean, it's really kind of a statement. It's not so much a substantive legal requirement. I think you did have some feedback from the Board of Licensure in Medicine that's attached for you following the public hearing. I think at the last page of the blue bill analysis, page 7, the boards didn't particularly discuss or take a position. It may have been inadvertently not included as to whether or not, you decide to put that back in. I think you're probably right. I'm not sure that the board would take action against someone if they, or would have the ability necessarily on a particular case, but it is something that was raised by the representative of the Christian Science community. So brought that to the community's attention.
Yep.
Okay.
Thanks.
So you also had some additional clarifications suggested by testimony that you received from the Maine Chiropractic Association that was submitted to the committee in writing. There are some protections in the current law, and again, this is also referenced in section 3270 that specifically reference the use of the title doctor by chiropractors and other licensed practices. That is included in current law in section 2233. The language instead authorizes use of the title when such a designation additionally contains the description of another branch of the healing arts for which an individual holds a valid license. I think that language appears broad enough to include the language, to encompass the language that's already in section 3270, which specifically authorizes the use of the title doctor for licensed chiropractors, naturopathic doctors, optometrists, podiatrists, and dentists. They are all specifically referenced in current law. But I think the draft that was presented to the committee, I think, seeks to replace all those specific references with that sentence I just said. Such a designation additionally contains the description of another branch of the healing arts for which an individual holds a license. I think it's recognizing that folks that are licensed can continue to, and have that ability, can continue to use that title. And in each of the licensing chapters for a chiropractor, a naturopath, a dentist, an optometrist, and a podiatrist, it includes language that specifically authorizes them to use the title of doctor associated with their license. So I'm not sure you necessarily need to clarify that, but you could put the language in 3270 back in place of that if you thought that the language proposed in the bill was not adequate. The second concern they raised was related to the definition of the practice of medicine, because the practice of medicine now is going to encompass both the training of allopathic physicians and osteopathic physicians. It does include specific reference to manipulation. Chiropractors also have authority to perform manipulation. And so the suggestion was whether or not additional clarification is needed to ensure that this language does not extend regulatory authority over chiropractors or inadvertently seek to do that. I don't think there's any intention to do that. It's just providing the authority and the definitions necessary to encompass licensing for both osteopathic physicians and allopathic physicians. And again, it's trying to carry forward language that's in current law into this new statutory chapter that would govern the Maine Board of Medicine. Finally, the testimony from the Maine Chiropractic Association also raised a concern related to the definition of a healthcare team that does not specifically reference a chiropractor. That language in the definition is taken directly from current law. The definition in title in 2233 does include a reference to other licensed professional, which would encompass a chiropractor, although they're not specifically referenced in that definition. If you look at the specific language, the definition of healthcare team is on page 2. And that really is a definition that applies with regard to regulation and oversight over physician associates. But a healthcare team is defined as 2 or more healthcare professionals working in a coordinated, complementary, and agreed upon manner to provide quality, cost-effective, evidence-based care to a patient, and may include a physician, physician associate, advanced practice nurse, physical therapist, occupational therapist, speech therapist, social worker, nutritionist, psychotherapist, counselor, or other licensed professional. Could certainly add chiropractor to that list if you thought it was necessary, but I think the or other licensed professional would include a chiropractor in my reading of the statute. In addition, the testimony that you received from the American Osteopathic Association and representatives of osteopathic physicians about merging the boards raised concerns about the potential effects of a merger. Their written
Colleen,
testimony.
Could I, sorry. I guess, well, just one really quick point. Nutritionist isn't licensed. The dietitian is. So if we're actually including licensed providers, that should probably say dietitian. But I'm curious why we list anybody out if pretty much everybody is under other licensed professional. Why don't we just do other licensed
You certainly
professional?
could do that. It's just, this is the current definition in
Got it.
statute, and we're just trying to reenact what's already there.
Perfect.
So
Thank you.
that's why it's suggested, but the
Thank
committee
you.
could certainly alter that definition if you thought it was necessary. The concerns, the range of concerns that were brought forward in the testimony from representing osteopathic physicians related to the specialized nature of osteopathic principles in practice. There is, under the LD 2233, the maximum fees are consistent with the maximum fees that are permitted for licensed allopathic physicians, MDs. So it would be up to $700 for an initial license. That is an increase for osteopathic physicians, which I think are currently at $350. So they noted that for the committee. They also noted the potential to steer away resources from osteopathic licensure and complaint adjudication, noting perhaps that there might be additional resources needed for oversight of international medical graduates, and other things were raised in their testimony. I would note, just for the committee's information, that you did get a response from the Board of Licensure in Medicine. Those are on pages 5, 6, and 7. And I think to the extent some of those, that they respond to a certain extent to some of those concerns that were raised in the written testimony with regard to resources and how they would address complaint adjudication involving DOs. You also heard some concerns about the quorum requirement in the legislation as drafted specifically with regard to adjudicatory hearings. Representatives from the Maine Osteopathic Association suggested that the language in the bill should be further clarified. As the bill is drafted, it states that 5 members are a quorum in order to conduct both an investigative hearing and an adjudicatory hearing. The language and the proposal that the boards are making to the committee is to establish a 22-member board, but allow an 11-member board to be appointed to govern the investigatory functions, and an 11-member board to be assigned to address adjudicatory hearings. And the language further states that members cannot serve in both roles pertaining to the same matter. The specific language, I think, that raised some concerns by the Maine Osteopathic Association is specifically on, if you look at the bill, it is on the top of page 23. And it refers to the requirements for adjudicatory hearings. And it says adjudicatory hearings must be conducted by an adjudicatory hearing panel composed solely of a subset of board members taken from among one of the 2 investigative committees, with a minimum quorum of 5 members serving as adjudicatory hearing panel. And I think that language is intended to say the adjudicatory hearings are conducted by the 11 members, and 5 of those is a quorum. But they have suggested perhaps the language might benefit from further clarification, just specifying that. I think that my understanding is that's the board's intent. You also had some suggestions that perhaps 5 was too low of a quorum to establish for these hearings. And the board response, I think, addresses that in part as to some of the operational difficulties or logistical difficulties too, that might occur if it was the quorum was higher. The statutory quorum in the bill, as I mentioned, is 5 members constitute a quorum for the conduct of an adjudicatory hearing, and 5 members constitute quorum of the investigative committee meetings. A majority of the board members constitute a quorum for the whole 22-member board. The committee can specify in statute what a quorum is by a specific number like that. 5 is less than a majority. Commonly, a quorum is a majority of the members. So if it was a quorum of the 11 members, it would be 6, not 5. But that would be the committee's. Committee could certainly make that change if you wanted to. Finally, I guess the last sort of issue that came up, I guess, of a substantive nature, is whether or not the language should be clarified to require that the legal assistance provided by the Attorney General's office must include separate individuals when providing assistance to the board when performing investigatory functions and adjudicatory functions. The testimony received from the Maine Medical Association and the Maine Osteopathic Association suggested that the committee include language to clarify this. There is current case law that's already being followed by the boards that provides the same assistant attorney general cannot serve both functions for a licensing board, and that licensing boards operate in accordance with that case law. And since the law court decided that case, the legislature has not made any statutory changes to codify the court's holding. If the committee does believe that additional statutory classification is necessary, I might suggest that it's not advisable to do it for just one licensing board and not all the others, because the court's decision applies to all licensing boards. And that is currently what is being followed, the practice that's being followed by the Attorney General's office. So I would say if you're going to do it for the Board of Licensure in Medicine, you don't do it for anybody else. The court might interpret that, why is the legislature doing that? Why aren't they, what are they doing? And so if you are going to think that's important to put that in the statute, my recommendation would be you should put it in statute for all the licensing boards, not just the Board of Licensure in Medicine, or the new main Board of Medicine. And whether or not the legislature does anything, the licensing boards and the Attorney General's office are currently operating in accordance with the case law, and the precedent and the holding that's been set by the law court. The last things really outline some of the technical drafting issues. If the committee moves forward with this legislation, I think you all know you have LD 2088, which makes some changes to the statutes governing physician associates. And LD 2233 carries forward the existing law that is in place for physician associates. If LD 2088 moves forward, that makes some substantive changes to provisions in here. So you have two kind of options, I guess, to address the conflict if both of these move forward without any additional change. LD 2088 is, if that is enacted, it does not have a specific effective date like this does. So this has an effective date of January 1 of 2027. So LD 2088 does need to go into effect if you want the statutory changes to be made to those existing statutory provisions now or in that interim period. And so what you could do is amend this bill to incorporate the changes made in LD 2088 effective January 1 of 2027. So I think, we can address those conflicts. It's going to be a lot easier if LD 2088 is enacted first, because then we can just amend it. It will move it forward. If it's not, if they're still kind of moving in parallel tracks, we can sort of change the language to be consistent, so they're both consistent. And so that law will go into effect for those existing provisions of statute will stay in effect until January 1 of 2027. And then those same changes can be incorporated here. So that's just one sort of technical drafting thing that will have to be addressed. There was also a suggestion, or I think a technical change will have to be made with regard to the timing of the election of the first board chair and vice chair in January of 2027 should be addressed. And that can be addressed in unallocated transition language. The language of 2233 would require that based on their current practice, they do it annually in July. So you could put some language in unallocated transition language, which is already in at the end of Part A to authorize an election to be held in that interim period. There's also should be some accounting for the term of board members following the merger on a staggered basis. That's typically something that's done in unallocated language. The current transition language allows current board members to serve on the new main board of medicine until their terms expire, and then they'll be reappointed. But there should be some addressing for when those new members come on. Typically, you don't have, when a new board is formed, you typically don't have all the new members having the same term and you stagger them. So that's something that we could do and model. If the committee wants to model it on how we do it typically with when other new boards are enacted. And then the last thing really is cross-references. There are a number of cross-references in other titles of the statute to the Board of Licensure in Medicine, to the Board of Osteopathic Licensure, because you're going to have a new board in January 1 of 2027. There'll have to be some cross-references, so we can address that through like a new Part C that will fix all those cross-references effective January 1 of 2027. So that's sort of like behind the scenes work that have to be done. If the committee moves forward with a positive, recommendation. Licensing of physicians in other states. Maine is one of 12 states that have separate licensing boards, so 38 states have a combined board. I think that came up in testimony, but I just listed those out there. And then finally, with regard to the fiscal information, a couple of things I would note. We don't yet have the official fiscal note or the fiscal review. The Board of Licensure Medicine testimony indicated that they have their estimated budget to implement the merger includes one-time costs of approximately $200,000. The allocation will be needed to authorize the boards to expend those funds before the effective date of the statutory of the merger. As drafted, as I mentioned, LD 2233 includes two parts. So Part A is effective 1/1/27. Part B is the sort of language that provides directive to the board to like further study and then present something next session if there need to be additional statutory changes. Any appropriations and allocations section that is necessary to authorize the board to expend funds prior to January 1 of 2027 can be added to Part B, so it can become effective prior to 1/1/27. So I think we can address any concerns about timing and authorization for the expenditure of funds. And then the last thing I would say is just to remind everybody the difference between an appropriation and allocation. The board has existing other special revenue funds to support these one-time costs. They don't anticipate having to increase any fees, but they need a specific allocation, which is the legislature's authorization to spend the funds on that one-time basis. So I will stop there and I'm happy to answer any questions.
Great. And since it's coming from OSR, will that land on the table or not?
It will
I feel
not,
like I
because
get
it's OSR, it
conflicting-
will, I don't anticipate it will land on the
Okay.
table.
Get conflicting information about that. Okay. Questions for Colleen? Representative Strachey?
Thank you, Madam Chair. Colleen, so other than the language from about the religious language, the religious practices, if I didn't have a problem with number 2, I don't think there's any substance to the worries of the chiropractic community. Not worried about number 3. I'm looking on page 2. Not worried about number 4. I think the quorum, I read the explanations from the others. I think I'm fine with 5, the way it's currently drafted. The technical drafting issues and the allocation of the money. Those for me, those are the things that if we wanted to leave it pretty much the way it was, it would be an ought to pass as amended with those would be the amendments.
Yes.
I'm going to make that motion. For purposes of discussion, that I'm obviously, but that I'm going to just put it on the table. So if there's a second.
Do I have a second to that motion? Yeah. Discussion? Representative Boyer?
Oh, that's me.
That's okay.
But that's with the religious language in.
Yeah. So it would be that language outlined suggested in number 1 on page 1 of the blue analysis, and the technical changes that would be needed that are outlined under 6. That's the motion. And the allocation, which will be, yeah.
Thank you, Madam Chair. I have a question, if the committee members will indulge me for a minute. On page 8 of the bill, Colleen, it references the annual report. And I had talked to Mr. Terranova. I had some additional, like when I read the annual report, I just wanted more information. And he made a great suggestion that maybe this would be the time. So if I wanted to see additional information in that annual report, could we add it here? So could I tell you what I would like, and then committee members tell me if you all agree. But I wanted to see a breakdown between MDs and physician associates. So that we weren't seeing just a new number of complaints, but it was being broken out. And then also the percentage of complaints in relation to the number of licensees. And this was information that Mr. Terranova gave me for 2025, but I would love to see it going forward. And the other thing I thought that would be helpful is just like historical reference. I mean, I know all these reports are online, but just to make it easier, I guess, for us, some sort of historical reference or last year's report also attached so that we can see, you know, the difference in complaints from year to year. I thought would be helpful. And I don't know how other committee members feel about those few changes.
Senator Bailey?
Just have a clarifying question, Representative Boyer. When you said you wanted it broken down, you said MDs and PAs. Did you mean DOs as well?
I didn't mean DOs, but I guess that would make sense. You know, MDs, DOs, and PAs. I mean, yeah, that makes sense.
All three.
Yeah.
Discussion from committee members? Representative? Yep, Olson.
But Josh had his hand up too.
No.
I guess the only, you know, when we're talking about the investigative and adjudicative, should we have some language in there that specifies that, you know, for an allopath, it has to at least have one allopath doctor on there, on that board, and if the osteopaths, same thing, so that we, you know, one of the concerns that came out was that you could have MDs totally on do the investigation and adjudication on a DO. And so should we have something there that specifies that you should have, you know, you need to have at least one member of that group on those boards?
On each of those boards, you mean on?
For the adjudication and the investigation, so that you're assured that you have a DO, you know, on the board that's looking, you know, that's investigating the DO, and you have an MD on a board that's investigating the MD.
So you, on page 21, it already specifies the membership of each investigative committee. So essentially, they're going to split the 22-member board into two committees. Committee A and Committee B is how they refer to it. And each of those committees must include 3 MDs, 3 DOs, 2 PAs, and 3 public members. And so of those 11, 5 constitutes a quorum. So I think you already recognize that there'll have to be so many of each number, and it'll be equal in number. But were you suggesting that in order to make a decision pursuant to a 5-member quorum, one of the people deciding has to be a physician or a DO? Is that what you're suggesting?
Yeah.
Yep, you could certainly do that. And I think it would
Because there
need
are
that
some-
clarification in
because
here. to
There
do
are
that.
some unique, you know, differences you can get into there. The MD may not be, yeah, that's there may not be conversant on the manipulative side. So, you know, we want to make sure that at least you've got someone from the same group on that committee.
Are you
I mean,
including physicians associates too, or are you just talking DOs and MDs?
You could,
Senator Bailey?
yeah.
I can help. So, I mean, I like the idea. I think it is important when you're making decisions about standard of care that you have, you know, someone who has your own same license. So I think it should be for all. So again, if you're making a decision about a physician's associate,
Yeah.
it seems like a physician associate should be a part of that decision.
I agree.
Yeah, so I think it should be all
All
of them.
I think it should be all of them too.
At least one. I mean,
Mm-hmm.
a minimum of one of the 5 must be, yeah, so that you couldn't have a situation where, you know, there's 3 public members, say you have 3 public, you know, I guess there's never be a situation where non-clinicians could make a decision because 5 is your quorum, but could be a situation where 2 DOs are there plus the 3 public members and they're making a decision with regard to an MD. And so that would be how you would want to clarify it. I think you could clarify that in the statute. I would say that that might happen now. But, under the current, standards or provisions that are followed, but, we would do that. And I think the place to do it would be right where I was talking about it, at the top of page 23 in that, paragraphs that are specific to adjudicatory hearings. So we'd add some language, probably a new paragraph or something that would specify that.
Additional discussion from members? So it sounds like we have two proposed changes to the motion.
I'm fine with that.
There are additional questions or concerns or discussions? Seeing none, I think we're ready for a vote. Oh, sorry, Sally. Yep.
I ran out to
Lucy.
the restroom while the motion was made. Can you just tell me what the amendments are to the?
Sure,
Is it?
Colleen
Okay,
can.
thank you.
Sure. Ought to pass as amended. I don't even know if do we ever get a second, Edna?
Yes.
Oh, okay,
Representative
okay,
Foley
great.
did.
Can we do it?
So it's ought to pass as amended, so it'd be the bill. We would add back in that sentence related to, religious practices. Make the technical drafting changes that I outlined, fixing the cross references, addressing staggered terms, appointment of a board chair, those things that are outlined there. We would make some changes suggested by Representative Boyer to the annual reporting requirements to have, reporting about, complaints, investigations, that's on page 8, I think. So we would supplement the requirements, now that the, statistics provided in the annual report related to the number of complaints, received, dismissed, adjudicated, carried over, those would be broken down by, MDs, DOs, and PAs. There would be a breakout of the sort of the kind of complaints and some additional historical reference, like year over year, how they compare. And then the last change that was just discussed is with regard to adjudicatory hearings, the quorum requirement would remain at 5, but we would add a requirement that there have to be a licensee would have to be part of that adjudicatory hearing.
Senator Bailey?
And maybe I missed it because there was some conversation going on behind me, but did you also talk about the allocation being added to Part B?
Oh, yes. I included that in technical drafting issues, but yes,
Okay.
I'll make sure, yeah. When we add it,
That's an important part.
more than technical.
when it comes back in. Well, normally it would be there anyway. It wouldn't go in Part A. It would be, it
Yep.
would, so I don't think it's a concern, but just to point out how we would address it, but.
So there's been a corner caucus requested, so we'll be back in 5 minutes. Welcome back.
Did you see the copy of?
She is in,
I think you should wait.
yeah.
All right.
Great, welcome back. I think we are ready for a vote. Thank you, Edna.
Thank you. Senator Bailey?
Yes.
Senator Bailey, yes. Representative Matheson?
Yes.
Representative Matheson, yes. Representative Alford?
Yes.
Representative Alford, yes. Representative Boyer?
Yes.
Representative Boyer, yes. Representative Shimino?
Yes.
Representative Shimino, yes. Representative Clucci?
Yes.
Representative Clucci, yes. Representative Flynn?
Yes.
Representative Flynn, yes. Representative Foley?
Yes.
Representative Foley, yes. Representative Mastracchio?
Yes.
Representative Mastracchio, yes. Representative Morris?
Yes.
Representative Morris, yes. Representative Olson?
Yes.
Representative Olson, yes. 11 members of the committee have been voted in the affirmative and 0 in the negative.
Congratulations. So I think we have some different language reviews and some fiscal notes to look over, but I wanted to kind of take the will of the committee. I know that we are going to have to do a work session on the bill that we just heard. So I think we have some quick fiscal reviews that we could do and maybe hold off on some of the more complicated language review. Does that sound? Because we're going to have to do a work session. But go right ahead.
We do have several people here in the audience that have been waiting all day, hoping that we do the language review on some of the more complicated bills. So just to take that into consideration.
Thank you. So maybe you could just give us a little summary of what the ones we have for, yeah, thanks.
So, what Ed is distributing there were, 4, amendments that already have the completed fiscal review. 3, the committee has seen before, and really 4. LD 378, you saw the language, when you voted, that, but the fiscal review has already been completed on that. So those are the ones that Edna is bringing around: LD 378, LD 1530, LD 1901, LD 2200, and with the addition of LD 1502 as well. So those are all on the orange that Edna's just distributed. What you had not seen were the completed fiscal reviews, which are at the end of all of those. The other things I had for you today to consider would be LD 2201, which were the additional kind of changes you talked about last week, and you wanted to see those in written in. I also had memos to the Judiciary Committee for a forward review of LD 2200 and LD 2201. And then I had a draft memo to AFA related to LD 107. So, so if you just did the orange, what would be left undone would be 2201, 2200, just those those memos.
In 107.
And 107, yeah.
Okay.
So,
All right, let's start on the orange.
okay. Well, I think these are in order. Oh, it's in here, sorry. Boards of people are over there wondering. So, they're the board back. It is, it's like very. But they're not they're not collated. Okay, so the first one is LD 378. This was the bill that the committee voted last week. An act to clarify that health insurers must comply with this plan sponsor's statutory rights to audit claims and related data requests related to those audits. This is essentially the language that the committee saw at the work session. In addition to the draft that the draft amendment that was presented at the public hearing, there were additional changes that were incorporated in a separate document that had been agreed to by Anthem and the Healthcare Purchasing Alliance. That's been incorporated into this amendment. So those are in sections 2 and 3 on page 2, clarifying the non-disclosure and data use agreements, and then providing some language related to the liability for disclosure of protected information. So that has been added in both sections of the amendment that are were part of the Public Law 2025, Chapter 487. So you'll see it as sections 2 and 3 on page 2, and on page 3, sections 7 and 8. So sort of combined those two documents that you saw at the work session into one amendment, and it has no fiscal impact. Also, it adds an effective date of July 1 of 2026. The whole thing is an emergency, but it will have a specific effective date of July 1 because we're not absolutely sure you're not going to adjourn before. And in order that to go at the July 1 effective date to go into effect without an emergency. It doesn't look like it.
Great, thank you. Looks good, thank you.
This is LD 1502. It's been a long time since you've seen this. But the language of this is an act to update the requirements for health insurance coverage of prostate cancer screening. You've seen this language, approved the substantive language, but the fiscal review had not yet been completed. This is a 12-to-1 report, so this is the majority report. The fiscal review has been completed now. It's on the second to last page. It does expand coverage, as noted, for early detection of prostate cancer. It will prohibit carriers from imposing cost-sharing requirements for these services. They apply to health plans issued or renewed on or after January 1 of 2027. Because of the effective date, it doesn't affect any future costs don't affect the current biennium, but it does note that there will be a state employee health plan impact of approximately $109,181 beginning in fiscal year 27-28. Those costs are split across the general fund, the highway fund, and all other, but you'll see the projected future costs for the general fund and the highway fund here. Although it doesn't require a general fund appropriation, my understanding is that if this moves forward, it will be referred to the special appropriations table prior to enactment because it has impact on future general fund costs.
Great.
The next one is LD 1530. This is a divided report. This was the legislation related to reimbursement for emergency medical services. The first 3 pages are the majority report, which just makes changes with regard to reimbursement for non-transporting emergency medical services providers effective January 1 of 2027 at 160% of the Medicare rate. This similarly, as I described for LD 1502, this has a potential cost in future bienniums to the state employee health plan. It's a little over $48,000 annually. So those are noted for you on page 4 of the salmon colored sheet. And the minority report expanded the current requirement in law that requires ambulance services to be provided by carriers at 200% of the Medicare rate for their current rate, whichever is less. That increases that to 300% and also includes non-transporting emergency medical services providers in the scope of that amendment. This also has a cost. And I apologize. I think I attached for you.
Yeah, I think the numbers are different than what the
The numbers
projections
are
are.
different.
So
Yeah,
should
but
be like 62. Also,
the numbers are slightly different, but I think the totals are noted to be the same, but they shouldn't be in the narrative.
right.
So on the first item too, and I'll have them correct it.
Yeah.
It's not 48,168.
Right.
It's more like
62.
29 something. Yeah. And then the second one, it's 48,168. So that's a error that I'll have corrected, but the numbers are correct in the general fund and highway fund projections.
That's not the summary.
It's just the narrative. Yeah. And I'll have the OFPR correct that. That total's just off on the item too. So thank you. Again, if this moves forward, either report would go to the special appropriations table first.
Okay, sounds good.
Wait, so can I,
Sure.
I just want to make sure I understand. So it's,
I think that the total was just incorrect.
but isn't the total would be the 41?
Oh, I heard.
For the item 3, yes, that's the correct total. If that's what you're looking at, which
But-
one are you looking at?
I'm looking at my report.
Yep, it's 48,168.
For the, because it combines these two numbers.
Yep.
Yeah. That's it, though. That's not a big number.
No.
No, neither are big numbers, but they'll
Okay.
have to get adjusted. But yes, you're right.
So from the state perspective, they're not big numbers, but so to do the more generous policy doesn't cost that much more. 42. Okay. All right.
1901 is the next one. These are 2 reports as well. You've seen the language for these 2 amendments prior, but you hadn't yet seen the fiscal notes. Page 11 is the fiscal information for the majority report. Because there are some enforcement provisions that allow the potential for the the Bureau of Consumer Credit Protection to bring enforcement action for violations. The bill may increase the number of civil suits filed in the court system. The additional workload can be absorbed. It does not require additional funding. The collection of additional filing fees may increase general fund revenue by minor amounts. Because these are minor, I don't anticipate this would require a referral to the special appropriations table if this went forward. The minority report has no fiscal impact. And I can explain more if you need a reference on what these 2 amendments do. But I think everybody remembers the shared appreciation mortgage
I
loans.
think so.
So one's a moratorium and one is fully regulated.
Right. The majority report is the
Majority is
regulation, the
regulated.
minority report is the moratorium.
Got it.
Yeah.
Okay.
LD 2200, this is the majority report. The minority report for this is ought to pass, which you'll see the voting sheet is on the back. This is the bill that relates to the regulation of non-compete agreements, no fiscal impact.
Great. Do you want to just do 107, the AFA, and then I think, yeah, I think that might be. That seems like that might be an easy one to do.
So Edna's bringing around a draft memo that has been suggested for the committee's consideration to the appropriations committee about a bill from the first regular session that's currently on the special appropriations table, LD 107, which is an act to require health insurance coverage for biomarker testing. It's been requested that the committee consider recommending to the Appropriations Committee inclusion of this language in the supplemental budget with some amendments. There's a markup of the suggested amendment. As the bill is currently, the current form of the bill, and that's the engrossed version, on the yellow, starting on page 3, would make the legislation, if it moved forward, effective for plan years beginning on or after January 1 of 2027. This proposes to make the effective date January 1 of 2028, both for the requirements in the bill to require main care to provide coverage for this testing and for private insurance coverage. So the committee would recommend that it be incorporated into the supplemental budget as amended. And it would necessitate a revision to the fiscal information, which would, as I understand it, remove the need for a general fund appropriation in this biennium.
Yep.
So would shift it out 1 year. An OFPR would have to revise this section, or the appropriations section, which is on page 8 of the yellow sheet. But if that would be the committee's recommendation for AFA's consideration. So this is just a short memo asking them to do that and providing the markup of a suggested amendment. This was a 12-to-1 committee report.
Representative Boyer. Thank you, Madam Chair. Colleen, I'm sorry, I was distracted in the beginning. Where did this come from? Did we do this?
We do what?
Yes, we did.
The bill, yes, you did consider LD 107. It was
Right,
suggested that the committee consider sending this. So this is,
Okay.
if the committee approves, we would do this. It's the first time you're
It's the
considering
first
this
time we're
issue.
considering the
Yes.
issue, but
This-
not.
whether or
the
not you
bill.
want to make
Yes,
this
I remember the
recommendation.
bill well.
But
Okay.
I just drafted it as if you were approving it, so it would move it along quickly, if you would like to.
My understanding, this was the bill sponsor's suggestion.
It's not who asked me, but.
Oh.
I heard others like this, but.
Well, I didn't hear about it at all, right this very minute.
All right, so discussion by the committee. Representative Arford.
I have two questions. Because I still am figuring out fiscal notes. Obviously, regardless of when it goes into effect, there is a fiscal note, but this doesn't mention anything about what's added on to our other fiscal notes details around the state employee health plan, the impact on that. Is there a reason that isn't included in this?
So this would be an amendment to an existing bill on the special appropriations table. And so it has a fiscal information, and the appropriations and allocation section is based on that. So this appropriations and allocation section actually only reflects the cost to the state.
Right.
And it really is just focusing on the costs to the main care program for the most part. There is a small funding related to the state cost of defrayal for the mandated benefit, which is at the top of page 9, which is $170,000 annually. I think there was a small impact to the state employee health plan, and I can tell you what that is because I have the folder here with me. But if this moves forward and the appropriations committee accepts the committee's recommendation to sort of move this language into the supplemental budget, there will need to be a revision done to the fiscal note, and there'll be an update to that narrative that's been provided. But I can, if you're wondering so there was $170,000 cost to the, for defrayal, that was estimated. And if you're wondering about the potential cost to the state employee health insurance program, that estimated cost was, from the fiscal note last time, The first impacted plan year was estimated to cost approximately a little over $38,209 annually. And those costs are split among the general fund, the highway fund, and all other funds. So the legislature really is only supposed to, is required to fund the general fund and the highway fund costs, which is a subset of that 38,209.
And
Representative Orford?
yeah, the other part of this is just, and again, I'm just trying to actually connect all the dots. So we're saying at the end, in our supplemental budget, there will be no costs for 25, 26, right? So the cost that's gonna come. Now, what are we saying here? We're postponing. So what changes here is just when the cost shows up, right?
Well, the effective date and the cost, yeah.
And
Effective
so,
date will be delayed, and so that will
Push out the,
push out the
Push out
need
the need
to
to-
make a general fund appropriation in this
So-
biennium.
with the next legislature, the 133rd, will they have to vote on the funding again?
It will be included in the baseline budget, but it will be included, and the legislature will have the ability to make a decision as to whether or not they wanted to continue to
Continue
appropriate
funding,
those
yeah.
funds.
Okay, thank you.
Senator Bailey. Additional discussion. What is the will of the committee?
I would say that we should go with the suggested change.
Okay, great. Do we have to do anything?
No, if you're good, I mean, I could, show of hands would be good, but if everybody agrees, then I can forward the memo on to the appropriations committee.
That by a show of hands?
Show of hands
for
is good.
agreement?
Unanimous. Well, I did draft the memo.
You just gave up your first
I
one.
will have to say, I did draft the memo saying that the committee voted 12-1 and it continues to support it, and you were the one. So the memo does say that
It's a good looking out.
the committee, the same members of the committee that supported it last time continue to support it. But if you'd like me to change it, I could change it to unanimous.
All right, I think we could probably do the FOA on 22.
Just the one.
Just the one. Yep.
That one tomorrow.
Yep.
Which one?
2,200.
2,200.
Just reviewing the follow-up.
I don't have that. I don't have that
I don't think
folder.
we can do the forward memo on 2201 because we haven't.
We haven't looked at.
finalized it.
Yep.
So this will facilitate the Judiciary Committee reviewing the confidentiality provision that is included in LD 2202, which is a bill that implements a recommendation of the Hospital Commission, I guess we'll call it, that would codify a requirement that notice be sent to the Attorney General. At the same time, notice is required to be sent to the Federal Trade Commission related to a merger affecting a healthcare entity. And this is committee's vote on that bill was ought to pass. But pursuant to statute, any confidentiality language must be reviewed by the Judiciary Committee before it's been reported out. And we've been sort of holding it to do in conjunction with LD 2201, which also has confidentiality language, but we could move this on individually to the Judiciary Committee. So it just really, the memo explains what the bill does, describes that the bill is modeled after the Uniform Law Commission's Antitrust Pre-Merger Notification Act. It's focused on mergers of healthcare entities. It's intended to require an electronic copy of the same materials filed with the Federal Trade Commission to be filed with the Attorney General. It provides for confidentiality of that information provided to the Attorney General, except it authorizes disclosure by the Attorney General under those 3 paragraphs, subject to a protective order entered by a court or judicial order. They can share information with the Federal Trade Commission, or the United States Department of Justice Antitrust Division, and they can share information with attorney generals of other states that have similar, substantially equivalent confidentiality provisions. The confidentiality language here is intended to mirror the confidentiality protections under federal law with regard to these pending mergers. So the rest of the memo just really describes why it's necessary for the Attorney General to have notice of these mergers, because they don't currently get them now. We're codifying it. It allows them to review and determine whether proposed merger has antitrust implications. It is a requirement under federal law that they have notice of these mergers. This is just codifying it under state law. We do think that the reason why it should be confidential is really because it involves sensitive proprietary financial information that may jeopardize the transaction and affect the competitive position toward other healthcare entities. Similar to how some of the language we've talked about previously and other confidentiality provisions, and just note that it's mirrored on confidentiality provisions in federal law. Hopefully it's a straightforward review by Judish. But you never know.
Questions or discussion? Seeing none, that's great. I think that's it for today, other than, yeah, we'll be doing language review on 2201 tomorrow and likely a work session on, I don't know.
Do it tomorrow?
I don't know. Depends on the will of the committee.
Well, and if Colleen can get.
And if
There was a
Colleen
lot
can
of
get, yes. There are a lot of requests.
Oh, for the, well,
Yeah.
I can't promise all answers to all the questions that you asked.
That's okay.
but
We'll
I'm
talk it through.
Ready for it otherwise, if that's what people want to do. Do my
Yes,
best.
Senator Bailey.
I mean, the committee can do what they want, but just FYI, I probably can't be here. I have confirmations at HED. So.
Senator Bailey can't be here because she has some confirmations tomorrow, so.
And housing. Yeah.
Okay, we'll hold off. Yep.
Gonna have to find another senator.
Yep, nope. we'll hold
Dig
off.
up another senator. That's all I'm gonna say. Great.
So
We do it tomorrow.
then I guess we'll ask Commissioner.
Yep,
Meet with
Monday?
sometime next week.
you might wanna just ask.
Yeah.
I just.
I'm
Representative
gonna-
Matheson, don't you love how I asked you to take the gavel and I'm being irritating. I apologize. Do committee members have a preference for a day next week?
Monday,
Monday?
Monday.
sooner the better.
Yeah, so,
To me.
yeah, to do the work session on 2242, language review on 2201, and obviously anything else that, gets ready between now and then. So it will be a short meeting, but
No. So we're not meeting at all tomorrow.
again, I can't be here, but if the committee wanted to meet, they certainly can. I don't want to hold it up just for me, but that's up to the committee. Representative Mastrangelo.
Thank you, Madam Chair. I guess I'm just trying to think that it seems to me that we should try at least to work that bill tomorrow, because if we need a little extra time, and we're not going to get, I'm hoping that we can work it and get done with it, and then it can get out there, because the longer we take, the longer it's going to take. We still have stuff that we've done here that still hasn't been pushed out. That's what I'm concerned about.
I am fine.
So I'm okay with
meeting
you
without
not being
me.
here, is
Yes,
what I'm saying.
and I am too. I would say if I felt differently.
You
but-
could start us and then we could, and then you can go do what you got to do. I mean,
What's the
just need
will
a
of the committee, and Colleen, how do you feel about that in terms of workload with all the questions that people had around
Well, like
it?
I said, I may not be able to answer all the requests for
Mhm.
information by tomorrow, but otherwise, and I might not have a analysis, but I could, a written analysis, but I could certainly walk you through it because I was prepared to do that today.
Okay.
If you moved into work.
Between Thursday, which is effectively Friday for us.
Just our senator.
And Monday we'll be doing it, right? If we don't do it tomorrow.
My preference would be to do it on Monday.
Yeah, I would do that too. Yeah, okay. So.
As these are last for me.
Thank you. All set? Thank you very much, guys. Good work.